all now. Option दे दीजिए.
Sorry.
Anil गायब हो गया वापस. So Anil, I think Rekha, you have told Anil the questions and.
Yes. I accept him.
No, everybody is on. No?
Dr. Anil is here.
Yeah, Dr. Anil.
So I think mute ourselves and then these guys can start. Okay.
Okay.
There is nothing on TOGS video introduction over nothing like this, no?
Yeah,
That is up to you.
everyone.
Mute everyone.
No, sir. We have muted everyone in the entry only. Only the co-host has the permission to unmute or mute. It's a subjective to them, sir.
Only co-host can unmute this, sir. Rest everyone will be muted now.
Okay, so you will, Munali, you will unmute or mute. You have
No. Co-host has the option as per his choice. He can mute or unmute himself.
The audience cannot mute and unmute themselves. We can do anything.
All panelists has been made co-host, so they have the choice with them.
Okay.
They have the choice to give. Yeah. Yes, sir. Prashant, sir.
I'll mute my mic now.
Okay, sir.
It is up to you, sir.
Thank you.
सर केव्हा सुरू करायचं सांगा. 3 वाजता.
आता बरोबर एक मिनिट थांबा. 1 मिनिटानंतर स्टार्ट.
Within a minute. Okay, fine.
Within a minute तुम्ही स्टार्ट करा.
We'll wait for 5 minutes, sir. अजून participants आले नाही.
1 minute. 1 minute.
जसं तुम्ही स्टार्ट कराल ना
तसे
People will start
तसे
joining.
येतात ते.
Okay, चालेल.
तसं नाही होत ते.
So exactly after 1 minute we'll start.
हा, exactly after 1 minute you start. Don't bother about audience. They will join automatically. आणि जसं हे तुमचं बेसिक झालं ना तसं टॉक्स वर टाका की वी आर लाईव्ह नाव. हे टॉक्स वर टाका वी आर लाईव्ह नाव जॉईन इन म्हणून. बरोबर आहे.
मी मगाशीच टाकलंय परत एकदा.
नाही आता हे तुम्ही बोला तुमचं बेसिक झालं ना की
I will put, if you want I will put it immediately.
हा, या इमिडिएटली टाका आणि एक फोटो टाका त्याच्यामध्ये. सर्व पॅनलिस्टचा एक फोटो टाका.
हा, मृणाली एक फोटो घेते का?
हा, तर तो रेडी ठेवा.
Rekha, I have taken. Don't worry, I'll put it.
Okay.
Fine.
Priya is there, not to worry.
Okay to start, Rekha?
Yes, sir.
Yeah.
Sir, चालू करूया आपण.
Okay.
Good afternoon and good morning, everyone. On behalf of Thane Obstetric and Gynecological Society, I, Dr. Rekha Tote, Joint Secretary and Chairperson Onco Committee TOGS, welcome all respected speakers, chairperson and delegates for today's webinar. This is our second webinar in a cancer series, first week done on cervical cancer, and today we are going to discuss everything about CA endometrium. We know that this is a vast topic and difficult to cover in 2 hours. I would like to request all delegates to please type your questions in a chat box and I will read it out for you so that we can cover more questions. Now, without wasting time, we'll start our webinar. I would like to invite Dr. Rajiv Laud, a president of Thane Obstetric and Gynecological Society, to introduce our first speaker, Dr. Nitish Rao. Over to you, sir.
Hello, thank you, Dr. Rekha. A very good afternoon to all of you and a warm welcome to all the delegates participating in this live international webinar organized by Thane Obstetrics and Gynecological Society Team 2021. The organizing secretary is Dr. Datta Panindikar and the organizing moderator is Dr. Rekha Tote, our joint secretary. The topic for today's webinar is comprehensive management of cancer endometrium. Friends, as you know, this is CO and endometrium is one of the commonest malignancies seen in perimenopausal and menopausal women. And also 20% is seen in below 45 years of age. So this cancer endometrium is directly related to our lifestyle, and in many cases it is hormone dependent, and it is showing an increasing trend. So to understand CA endometrium better, we have invited esteemed faculty from North Midlands, United Kingdom, where Dr. Nitin Raut will talk about diagnosis, staging, and criteria for surgery. This will be followed by Dr. Prashant Bhambre, who will give us an idea about minimally invasive surgery and lymph node dissection. That will be followed by Dr. Sandra Soho, who will tell us about the advantages of doing robotic surgery. And that will be followed by radiotherapy and brachytherapy, Dr. Rajni Bhana. But before we start this academic feast, I want to make a vote appeal, because Joint Clinical Secretary is contesting for the Managing Council. So please vote for him, as our Dr. Priya Ganesh Kumar has won with thumping majority. We also want to win. We also want Dr. Abhishek to win with a thumping majority. And also there is associate member of talks, Dr. Niranjan Chavan, who is contesting for the post of treasurer. So also please support him, all IG members of talks. So now I will start introducing Dr. Nitish Raut, our first speaker. Dr. Nitish Raut is a consultant gynecologist with a special interest in gynec oncology. He has completed his post-graduation from the University of Mumbai, India, and completed his general obstetrics and gynecological training in West Midlands. He has been trained in few oncology and gynec oncology centers in UK. He is currently a consultant gynecological oncology surgeon in cancer unit in the University Hospitals of North Midlands. He specializes in cancer diagnostics and laparoscopic surgery in ovarian, uterine, and vulval cancer. So with this brief introduction, may I now hand over the mic to Dr. Nitish Raut for his most anticipated talk. Over to you, Dr. Nitish.
Thank you. Hello, everybody. Sorry, I think I came to the end of the screen. Hi, everybody. Dr. Nitish Raut. Nice to connect back with all the old colleagues and senior colleagues and old friends. So what I'm going to do is I'm just going to start sharing my screen, and then we'll go through the talks about the endometrial cancer. Guys, can you see the screen?
No.
Okay, fine. Just a moment.
Yes, it's coming now.
Okay. Hi. So endometrial cancer, thanks a lot for giving me a chance to speak at your esteemed society webinar on endometrial cancer. I'm going to talk about endometrial cancer, its types, its grading, a possibility of a patient profile, and her journey from the time she presents with the symptoms till the time she gets treated, the various modalities of diagnostic, including ultrasound, CT, MRI, maybe PET, or hysteroscopy, endometrial biopsy or sampling, and the criteria that we use for surgery over here in UK. Yeah, I can talk about the UK incidence. As Dr. Rajiv sir rightly said, that the incidence of endometrial cancer is increasing. The more Western the world becomes, the more likelihood of endometrial cancer increasing. You can see that last year, I mean, they always do 3-year slots. So between 2015 to 2017 was a time when they had done the studies. Now the 2021 will give a better insight, because from 2018, 19 and 20 would be studied in 21, and then the results would be out. But over a period of time, we have seen that it's almost reaching 10,000 cases annually in UK. With and in same in 1992, it was 3,912. Now we can attribute that to better diagnostic abilities, or we can attribute it to the better lifestyle changes. Basically, it's one of the most common gynecological cancer in UK, and the fourth most common cancer in women. Basically, 2/3 occurs in women more than 55 years of age, and only 4% are younger than 40. It's predicted to fall by 7% over 2035, possibly because of better diagnostic and changing in the lifestyle. But the good part of it, it's not all doom and gloom, but it's the good part of it. It is 75% of the cases are diagnosed in stage 1. And if they are diagnosed, then 5-year survival rate is even more than 95%, which is a good thing in itself. One of the thing that has been noted about endometrial cancer is it does not differentiate. It treats everybody equally, whether you are deprived or whether you are from affluent areas. It's not related to any age. The only thing that it predominantly changes is the age. You can see that as the women's age goes on increasing, the incidence of cancer kind of gradually goes on increasing. You can see over here at more than 85, 90, it's very high. Whereas this is fairly static over a period of time. I mean, it's increased, definitely increased, but fairly static. This age group is between 50 and 60. Again, as you can see, it's increasing. So we depends on the year as well as depends on the age of the patient. You can see that it's gradually creeping up, especially in the senior generation. The FIGO Committee on Gynae Oncology has clearly stated that endometrial cancer have to be surgico-pathologically staged. Not, I mean, we have to do surgery as well as pathology. Histologically, the way we need to do is by identifying the tumor grading and the extent of the tumor, which can be done by radiology. Now, 94% of the uterine cancers are endometrial adenocarcinoma. And the grading, basically, we can just see there are two aspects to, if we see this image, we see that endometrium is 94%. Myometrium fundus, myometrium means the fibroids or sarcoma is less than 1%, fundus, isthmus, but it's the endometrium which takes a big chunk of 94%. Then grading basically. So grading basically it depends on the degree of cellular differentiation, like microscopically, how much changes have happened in the nuclear. Either it can be because of recurrent biological insults that have been happening over a period of time, and hence the DNA has to undergo a structural changes to its existence, structural changes to repair the damage. And in that process, it predisposes to cancer. And it's also essential for us to know the grading. The staging we can always find out, but the grading is also essential because it predicts the recurrence and helps us select the patient for post-operative radiotherapy. The most common place where they migrate to or metastasize to is pelvic and para-aortic lymph node, which is what I think Prashant and Sandra are going to talk after me. This is the staging, which is stage 1A, means it's restricted to the endometrium. Or even if it goes into the myometrium, it is less than 50% of the thickness of the myometrium. Stage 1B is where it goes into the myometrium and it's more than 50% of the myometrium, but still it is restricted into the uterine corpus or the body of the uterus. Stage 2 is it extends into the cervix of the lay patient. So it's gone beyond. So whether it's gone 50% or less than 50% doesn't make any difference. The moment it hits the cervix, it becomes a stage 2. Now stage 3, it goes beyond the uterus, beyond the uterine serosa to go into the parametrium or the sides. That is known as stage 3A, where it goes into the ovary or through the myometrium into the adnexa. And stage 3B is when it goes into the vagina or the cervix. Basically when it goes into the vagina through the cervix. Stage 3C, when it goes into the lymph nodes, basically. So if it goes into the pelvic lymph nodes, it's stage 3C1. And when it goes into the para-aortic lymph nodes, it's stage 3C2. And when it goes beyond the pelvis, either it can go into the bladder or bowel, then it's 4A. And if it goes into the other metastases like liver, lungs, brain, anywhere else, then it's 4B. Now, this is very, very important for us to plan, which is where Dr. Bana and Dr. Su come into being. The types of endometrial cancer is type 1, grade 1 and grade 2 endometrial adenocarcinoma, as I said, form almost more than 90% of the cancer. And type 2, any non-endometrioid cancer, either it can be grade 3 or it can be serous clear cell undifferentiated carcinoma, malignant melanoma, which forms about 10%. Now, why are they important? Type 1 tumor and type 2 tumor. Type 1 tumor is relatively better of the tumor because it's estrogen dependent, happens in relatively young patients. I'll just show you. It occurs as a result of continuous stimulation of the estrogen. Grade 1 and 2, and even if it invades the myometrium, it does not go beyond the uterus, and hence it's relatively superficial. The type 1 tumor has got infrequent lymph node metastasis, and it's associated with hyperplasia. And in short, as I said, it's got a better prognosis because we know if estrogen excess, yes, get rid of estrogen, do a surgery. The 5-year survival rate is much better. The type 2 is completely independent of estrogen. It is associated with estrogen at endometrial atrophy, rapid progression, and comes at a more advanced stages. There is a risk of the mutation, the gene mutation, and there is also, even if we treat, it has got a poor prognosis, and B, it has got a high risk of relapse. Now let's go to the risk factors. As we know the age, we just saw the screen previously, and that shows the more number of years the woman adds to her age, the higher chance of her developing cancer. Why? Because as I said, recurrent insults, the DNA has to undergo changes. The next is the famous corpus cancer syndrome, diabetes, obesity, and hypertension. Diabetes and obesity go hand in hand. But these kind of women have got a higher risk of developing endometrial cancer. Any process that causes unopposed estrogen state, again, overweight. Why overweight? It's not because nowadays any problem that happens, it can either be because of smoking or obesity or because of global warming. That's not the case. But overweight patients have got loads amounts of adipose tissue. Now, what does adipose tissue do? The adipose tissue helps to convert the peripheral androgens. All human beings have some or other amount of androgen in the body. They help to convert the peripheral androgens into estrogen. So a woman per se has got her own supply of estrogen. On top of that, all the peripheral conversion of estrogen keeps on occurring. So because of this, they have got higher estrogen exposure, and any unopposed estrogen exposure causes increased thickness of the endometrium. With no progesterone being there, the maturity doesn't take place, so it keeps on just multiplying, and anything that multiplies incessantly causes cancer. Same goes for nulliparity, because when a woman gets pregnant, this continuous stimulation of the estrogen, increased shred goes away, and many of the times it's seen that nulliparous women tend to have an anovulatory cycle where there is no ovulation. So what happens because of this is, again, continuous estrogen. Then some patients who've got PCOS, again, have got higher chance, less number of ovulatory cycles, and hence unopposed estrogen. Early menarche, late menopause, Again, duration of estrogen is great, and or any unopposed estrogen therapy. Say HRT, oh, woman comes in, oh, I'm having hot flushes, mood swings, menopausal symptoms. Whenever you give them HRT, if for any reasons it is not given, it is the progesterone is not given, that causes a problem. That's known to cause a problem. Tamoxifen. Now, tamoxifen is normal. It's a beautiful drug. It's used for breast cancer treatment. Hang on, I'm getting some. Fine. No, sorry. I thought I got a reminder of 2 minutes. Was it?
No.
Fine.
Please continue.
Sorry.
Please continue.
Something came up on the screen, so I thought, was it the 2
That
minutes?
is for delegate. That is for delegate.
No, that is for delegate.
Okay, fine. Sorry. So tamoxifen is a beautiful medication. It is used to prevent the recurrence or prevent breast cancer or help a patient recover quickly after the breast cancer surgery. It also prevents the cancer recurrence on the contralateral breast as against the same breast. Why? Because it acts as an estrogen antagonist at the breast receptor level. But it's a unique medication. It's called estrogen agonist antagonist. So at the breast cancer level, it acts as an antagonist, but at the endometrial level, it acts as an mildly agonist. So what happens is continuously gets stimulated, and we're talking about 5 or 10 years of tamoxifen exposure that predisposes a woman to develop endometrial hyperplasia followed by endometrial cancer. Again, next one is endometrial hyperplasia. Again, that because all this causes endometrial hyperplasia, unchecked hyperplasia can cause cancer. Or family history of Lynch type 2, which is also known as hereditary non-polyposis colorectal cancer. They've got a small gene mutation where the woman is more predisposed to develop cancer. The lifetime risk is 40 to 60% that the woman will develop either endometrial colorectal cancer and 9 to 12% ovarian cancer. So we get patients who've been worked up and we have to do a hysterectomy on them. They've already had their half of the colon removed also. It's challenging surgery, but interesting. Postmenopausal woman, the most common sign is postmenopausal woman. It can be in any form. It can either be in form of a spotting, like a light period, like a heavy period. Oh, it was there 5 days ago. Patients many times are in a denial. They do not want to accept the fact that something's abnormal. So what happens is if they come early, then yes, it picks up early. But if they come late, then we miss out. But only 6%, approximately 6 to 10% of the patients who present to us with postmenopausal bleeding actually have got cancer. Most of them are got atrophic vagina. And if it is irregular premenstrual bleeding, which is not responded to standard treatment, we'll come to that in the next slide when we should do that. Then again, this can be the case. They can also present with pyometra or vaginal discharge, pelvic pain, urinary or bladder symptoms. I mean, they prefer to ignore, and then they can come with either a hematuria or bleeding to the rectum. Or asymptomatic, like she's being investigated for some renal problems or something else, and suddenly we realize that the endometrium is thick, then we investigate. So endometrium more than 10 millimeters and asymptomatic, we still take a biopsy. Diagnosis, of course, there's nothing beats a clinical examination. But ultrasound scan is one of the gold standard for measuring the endometrial thickness. This is followed by a histological diagnosis, either in form of a biopsy or curettage, and then radiological staging, which is what will come to that, MRI, CT, or chest X-ray. Scan is done by sonographers, so we don't require to use the so the radiologist can be free for looking at complex cases. They measure the uterine size, the endometrial thickness, mention whether is it regular or irregular. If it is irregular in outline, if there is intrauterine fluid, or if there are adnexal lesions, then there is a higher chance that it can be endometrial cancer. So when do we do the people biopsy? If woman who comes to us with PMB on scan has shown that the endometrial thickness is 4 millimeter or more, then we definitely need further assessment, either in form of a biopsy, ideally speaking, hysteroscopy and biopsy. And if it is less than 4 millimeters, then all that we do is an examination and reassurance. The sonographers have got a very high sensitivity ability. So we never, maybe in a span of 7-8 years that I've been working in the unit, Maybe one case which had got an endometrial thickness of 2 millimeters, we didn't do anything, and she came back to us after 7 years, and she had got endometrial thickness of 5 millimeters. We took a biopsy, it turned back as cancer. So we are reviewing the case. But otherwise, if you see, the protocol and policy have been followed. Patients who are more than 40 years of age and who've been presenting with irregular PV bleeding for more than 6 months, or if the patient has to have a biopsy as a part of their workup, and if the patient is less than 40 years of age, has got irregular PV bleeding and comes in the high risk category, either she's obese or she's got infertile or PCOS or she's got anovulatory cycles, then we know that she's at a higher risk of developing endometrial cancer. Just take a pimple biopsy. Hysteroscopy is the next gold standard because we do that. It's being done under a local anesthesia, under direct visualization. 95% of the uterine abnormalities can be picked up. Its sensitivity for polyps and submucosal polyps or any obvious lesion is very, very high. And when we do a hysteroscopy, we have a look at the neovascularization. A woman who's gone through the change, who's got menopause, should not have any activity going on in the endometrium. And if there is a neovascularization, that means that part is rapidly multiplying. That requires more blood, and there is at least a higher risk of it being cancer or pre-cancer, like hyperplasia. Necrotic surface, again, it would be cancer then. We do an endometrial biopsy. We don't do nowadays a DNC because it's not indicated. Other modalities is chest X-ray. Now, chest X-ray, there have been, most of the units do it just to rule out if there is any concomitant abnormality in the chest. But if it is grade 1, stage 1, then we just offer them a hysterectomy. But if it is grade 2 or anything above, then we do a thorax, abdomen and pelvis CT scan. Why? Because that gives a better visualization if just in case if the lymph nodes have gone, if the endometrial cancer has metastasized into the lymph nodes. It gives, some of the centers prefer to do an MRI for advanced, intermediate or advanced level lesions, because it gives a better assessment of myometrial invasion. It is which itself is a better prognostic factor of in terms of predicting the lymph node spread, and it's useful for oncologists. Rajni will vote me for, will say yes, for planning further radiotherapy and management and seeing which patients are going to be responding. So typical patient profile that comes or journey that comes, patient has got PMB, as I said, in either form, either in like the period, like a light period, some spotting seen on wiping herself, or any time. Then she goes to the GP. The GP does a quick examination to rule out any obvious pathology like cervical polyp or atrophic vagina or a pessary.
2 minutes.
And then,
Dr. Nitin, 2 minutes left.
Okay, fine. Thanks. It will be finished in 2 minutes. Then she gets referred to one-stop PMB clinic, which is the secondary care pathway. We get a scan done. After the scan, she gets seen by the clinician. If the endometrium thickness is less than 4 millimeters, then we examine, reassure, and discharge her back. And if it is 4 or more, then we quickly do a pipel. If more than 10, then we definitely do a hysteroscopy, biopsy, and a polypectomy. And then send a histology on the urgent pathway to be reported within 2 weeks. After this, she is discussed in every single case that has been referred to the diagnostic cancer diagnostic center unit. Is discussed by the gynae oncology surgeon, radiologist, pathologist, oncologist, advanced nurse practitioner, scientists, gynae support nurses, cancer patient pathway coordinators, and their trainees. So the management, surgery is the gold standard, which is what Prashant and Sandra would be discussing. Medical, we do it patients who are not fit for surgery, inoperable, we give them high dose of progesterone. If it is for fertility sparing, we've got some cases where we had to do some fertility sparing, then we also try to manage it on the medical lines. When we do the surgical management, we see if the patient is fit for surgery, where and what type of surgery, whether it needs to be done in a cancer unit or a cancer center, and what type of surgery, whether is it a hysterectomy or, of course, hysterectomy, but whether is it a laparoscopic hysterectomy or an open hysterectomy. And by whom? By a suitably qualified person, depends on cancer unit or cancer center. Stage 1A or 1B, which is limited to the corpus or the body of the uterus, we end up doing a hysterectomy. As I said, in a cancer unit, TLH plus BSO. Stage Grade 3 and high grade get operated in cancer center, hysterectomy BSO plus minus pelvic and or para-aortic lymph node dissection. Again, fertility sparing surgery has got higher dose of progesterone, Mirena, put a Mirena coil, follow up with a hysteroscopy biopsy, repeat imaging in 6 months and see whether it gets response. The response rate is good, 75%, but the recurrence rate is also high, 30 to 40%. So that really doesn't give. So we get a small window of opportunity, ask her to either get pregnant or conserve the ovaries or egg freezing, and then we proceed. Endometrial cancer can either be low risk, has got a less than 5% risk of spreading to lymph nodes. Intermediate risk or grade 3, which are grade 1 and 2 endometrioid with more than 50% of invasion, have got 5 to 10% risk of spread, and high risk, anything else, has got more than 10% risk of this spreading. For stage 2, we do a modified radical hysterectomy, pelvic lymph node dissection can be considered to obtain a disease-free margin. And we aim to complete macroscopic cytoreduced surgery for stage 3 and 4, which is what we'll talk about later.
So we have crossed 20 minutes, 21 minutes.
Yes, then I'll come to summary then. Thank you. What a timing. Thank you. If there is a rising incidence, early presentation, better survival rates, presence with PMB, staging is surgico-pathological, one-stop clinic, hysterectomy, TLH BSO, operated by person suitably trained, and pre-op review. Routine pelvic clearance is not advised in early stages. Thank you. Okay.
Thank you, Dr. Nitish. Thank you very much. And sorry, I was just behind you for another 1 minute or so.
No, that's nice. It's very essential. Sometimes we get carried away while talking.
Yes, that's true. Is Dr. Datta on the panel? Is he joined? No, I
Yes,
think
doctor. Yes, doctor. He's there. Dr. Datta is there.
Dr. Datta is there. Okay.
Yeah.
So now, thank you, Nitish sir. It was a really wonderful, nice session. And now we'll move on to second lecture by Dr. Prashant Bhamre. I would like to invite our second chairperson, Dr. Datta Panandikar, who's the Secretary General of Thane Obstetric and Gynecological Society. And he will introduce our second speaker, Dr. Prashant Bhamre.
Excuse me, doctor. He has again left probably.
Yes, ma'am. Dr. Datta is not here.
Okay, then I would like to introduce Dr. Prashant Bhamre. Dr. Prashant Bhamre is an advanced gynec endoscopic surgeon. He's a proficient medical surgeon with exclusive practice experiencing in advanced gynecology endoscopic surgery since 2004 and 15,000 plus surgeries to credit, along with an association with the leading hospitals in India and overseas. Lead minimal invasive surgery with Ian Donald and Inter-University School of Medical Ultrasound LLP. Dedicated to exemplary patient outcome and following all necessary medical procedures with the use of latest industrial equipment and technology. Years of solid experience in teaching with a strong focus on training, packaging, and postgraduate gynecologist in advanced gynecology endoscopic surgery, that is minimum access surgery. Known for handling the most complex surgeries in India as well as overseas. He operates regularly in Cameroon, Nepal, Sri Lanka, Nigeria, and Bangladesh, etc. So I would like to invite Dr. Prashant Bhamre on the dais, please.
Hello, everyone. Nitish, it was a very informative and a very good lecture. I think all of us who are doing benign as well as, to some degree, oncosurgeries, I think it's a very informative in terms of what to see and what to do. And most question answers probably that you would have in panel discussion are probably answered here. So my topic is very clearly in terms of surgical steps only in laparoscopy in terms of endometrial cancer. So the crux of the surgery that routinely what we do a total laparoscopic hysterectomy for benign cases, and what is the difference between malignant. In malignant conditions, as Nitish clearly mentioned, that you have to do an extrafacial hysterectomy, that is the margins is to be disease free. In terms of pelvic and para-aortic lymph node dissection, already has been discussed in terms in early stages around 5%, and in late stages para-aortic lymph node dissection is around 5 to 10% again. So routine dissection of pelvic and para-aortic lymph node dissection, Sandra will discuss with you whether it's required, not required. the morbidity and the mortality issues or the follow-up treatment, how does it differ? Now, the hysterectomy part is same as in benign surgeries. You desiccate and cut the corneal structures. You can take the tubo-ovarian ligaments, the IP ligament or the tubo-ovary with the specimen, or you can do it separately. You skeletonize the uterine artery and the vein. You dissect the bladder down. Then you can use vessel sealing or your regular bipolar scissors or any instruments what you're using to lateralize the uterine artery. You can do the uterine artery the origin also if required. And then you have to cut off the Mackin rods and uterosical ligament. You open the vault by routine your colpota measure. And later on, I personally do the tubes and ovary later on because they keep on falling on the laparoscope. Okay. So go to the next slide. Okay. Lymph nodes, we have, I think the incidence, everything discussed. So the excision in terms of lymph nodes and pelvic lymph nodes, all of us are aware. We go till the obturator lymph nodes, the common iliac lymph nodes. In terms of para-aortic, again, depending if you have a scan or a PET CT, depending on what active lymph nodes you find, you go on the dissection. The only thing is, as we'll when we show the video, I'll show you how to go about it. I think I'll skip this slide because I think we have already discussed in terms of nodal metastasis, how does it happen. Sentinel node, Sandra is again going to discuss, but generally speaking, now this is in vogue. We use two types of things. We use methylene quite common in India and ICG also. But ICG is again a technology-based investigation. So you have to have an ICG camera system. But the most biggest sensitivity is ICG compared to methylene blue. Okay. So how do we do it? Practically, this can be used for both ICG as well as methylene blue. Inject 1 ml with a 27 gauge needle into superficial, that's 2 mm depth, and then 1 centimeter depth in cervical stroma at 3 and 9 o'clock position prior to the hysterectomy. Okay. Then other lymphatic mapping techniques such as fundal injection or hysteroscopic injection do not have the convenience of sensitivity. So we don't do it routinely, but cervical, definitely all of us can start doing it with methylene blue. And later on, if you have the ICG system, you can use that. This is how it looks on ICG. So after injecting around 15 to 30 minutes, you can see the lymphatics with the lymph nodes. So the idea is to see the lymphatics very clearly. So if you seal the lymphatics, obviously, you have lesser lymphatic collection in the patients. Okay. So sentinel lymph node is the technique which has come now, I think, which will become a standard in terms of at least endometrial cancer, the endometrioid variety only. Okay, rest of the malignancy has not been so proven, but endometrioid definitely. So usually what we do is a transmeningeal approach for all the pelvic lymph nodes because we are going to do the hysterectomy also as a part of the surgery. So I dissect the peritoneal folds before because as you progress in laparoscopy, the peritoneum tends to become more and more opaque and turgid. So you can dissect the spaces and keep it open. You can do the lymphadenectomy later on, followed by the hysterectomy. Okay. So while we discuss the video, then I'll show you how to go about it. So the pararectal and so in terms of the lymph nodes, all the spaces, the avascular spaces have to be developed. The paravesical, pararectal spaces, the ureter, the whole flow, the whole length of the ureter and the internal iliac, so that you can dissect the lymph nodes from the internal iliac, common iliac, as well as external iliac lymph nodes. Okay, so, and you should have no, in terms of adherent nodes, you should be very careful in terms of iliac vessels. Okay, we'll just go to the video. Can you see the video?
No, sir.
No, sir.
No, sir.
Yes.
Yes.
Okay. So we started with the hysterectomy. We are using a routine bipolar. This is Bissinger and the ultrasonic instrument by Johnson, the harmonic. So you can use bipolar and scissors, or you can use your vessel sealing devices, whichever you are comfortable with it. Only thing you should remember for all hysterectomy purposes, you should desiccate more and cut less. Okay, so any cutting instrument like scissors or ultrasonic, the tip of the instrument should be used. Okay. First, to start with the corneal structures, as I told you before, I remove the tubes and the ovaries later on because they keep on falling on the specimen and dissecting posterior becomes a difficult job. Always you dissect the bladder through a lateral window because even if the patient is previous C-sections, the space above the uterine artery is usually free. So you have to manipulate the ultrasonic or the scissors in such a way that you're above the artery and the plane is always seen. Like in routine C-sections, what we do is you start from the center. I think a lateral approach in previous sections or previous surgeries is much better and a faster approach. So if you're worried about the bladder, you can keep the active part of the harmonic away from the bladder and push the bladder slowly. So that is the avascular space, what you can see. Somebody is holding the bladder, lift the bladder. So we use a vaginal manipulator in this patient. So if you don't want to use, you'll have to use a tenaculum to manipulate the uterus. The traction has to be steady, and traction, a variable traction would give you variable effects in terms of all the energy devices, whether you're using vessel sealing, whether you're using ultrasonic, or you're using a regular bipolar. Okay, the logic of skeletonizing the blood vessels is that, one is the ureter falls more down if you dissect the posterior fold nicely, so your ureteric injuries are avoided. And secondly, skeletonized vessels, if you have tissue attached to the blood vessel, especially the uterine vein, it will tend to drag the vascular bundle down, and if there is oozing or bleeding, you tend to go more and more down and cause ureteric injuries. So skeletonization of the uterine bundle is a good technique for all of us to follow. Okay? Remove all the tissue on the arteries and the vessel, so that there is a clean vessel bundle seen for you. So dissect the posterior fold also. The advantage, as I told you, there are two advantages. One is the vessel is skeletonized, the vein is free, and the ureter also falls more down. Okay. So you can see the blood vessels very clearly. You can see the ureter also. So I've opened the spaces before, so which is not seen right now, but I can show you later on. The spaces are very clear when we show the lymph node dissection. So remove all the tissue on it. Manipulate the uterus in such a way. We use a simple vaginal manipulator, which is, I think, an Indian-made manipulator. What we are using. So you can use any manipulator where the vaginal manipulation becomes easy for an assistant to use. Okay. So repeat the procedure on both the sides, on the left side, on the right side, the similar way. Take the cornwalls again. Use bipolar or vessel sealing or harmonic and open the space. So I usually do an ipsilateral surgery, that is the left lower port and right upper port, which is in the midclavicle line. And I have an assistant port on the right side, which is in the lower port. So you can use midline port also, you can use a contralateral port, it is your choice, as long as the ergonomics of the surgery is proper. You can use table tilt or head low. So if you're operating on the right side, you can take the right side up. If you're operating on the left side, the sigmoid is falling too much, you can always fix the sigmoid and go and do the surgery. Okay. So take out all the tissue whichever is there on the stump, where the vessels, dissect the bladder as much as possible. So while cutting the vagina, whether you're using monopolar hook or using bipolar scissor or ultrasonic, there is no spread to the bladder. So usually we lateralize the stumps nicely. That the reason being, if you lateralize the stumps nicely, then only the wall can be cut very cleanly. If the vessels are very close to the wall, then the angle of the vagina tends to bleed more. Okay. So lateralize you can see the uterines are almost taken parallel to the uterus, so you get a stump as in open surgery. So any amount oozing or operating potency can be tackled very easily. Okay. Keep on lateralizing the vessel, then put a colpotomizer tube. You can see the bulge. I don't put the tube before, but you can put if you are if you want a bladder dissection, it's much more easier to do it on the tube. Now we have put a vaginal tube and pushing the bladder down as much as possible. Okay. I personally don't use much of monopolar technology, but it is your choice. Only thing while using any energy device like bipolar or monopolar, use the lowest settings. Use always the purest settings in terms of monopolar. That way, you would have less lateral spread. In monopolar, always touch the tissue and then activate. That way, again, lateral spread or complications of monopolar energy can be prevented. Take the complete cervix. Don't dig on the cervix. Take a vaginal incision. You can see the tube inside. We have taken quite below as compared to the regular laparoscopic hysterectomy, where you cut very flush to the cervix. So you've taken a comparatively better margin. So there are no chances, I think, of any spread or anything like this. So you can see the blue color is the vaginal colpotomizer tube. So the active part of the instrument is towards me, the inactive is below. You can use it like a hook also. because in ultrasonic only one part of the instrument is active, the rest is an inactive part. Okay. So you can keep on changing the instruments to lower port to upper port depending on your comfort level or getting a proper angle. So you're cutting the uterosicles and the macron right now in the posterior fornix. So you can antivert the uterus to, so that you can get a clear view of the posterior thing. I use a regular 30-degree 10 mm telescopes. A lot of people use 0 degrees. If they're comfortable, they can use. Only advantage of 0 degrees, you don't require a trained assistant. But for 30-degree, you require a qualified assistant to show you in various angles, because the vision with 30 degrees is much better than a regular 30-degree regular 0-degree telescope. Okay. Once you finish the hysterectomy part, either you put some gauze pieces or a bag inside the vagina, and then do the lymph nodes, or you can simply create some space in the vagina and then put it. Do not close the wall before the lymphadenectomy. Okay. You can just forward slightly. Okay. Okay, now the uterus has been totally disconnected. We are doing a salpingo-oophorectomy bilateral. The tubes and ovaries are removed later on. You get a lot of traction on the structures. So any adhesions in the ovarian fossa can also be tackled very immediately. Okay, so we do a bilateral salpingo-oophorectomy. Lymph nodes. So do a bilateral salpingo-oophorectomy and put it along with the vaginal bag. I'll just show you the lymph nodes now. Now we'll just go about lymphadenectomy. So as I told you, we have already opened the spaces before. So I start opening the pelvic spaces from the lateral side, that is from the psoas muscle. The idea being psoas muscle is a structure. It is easier to dissect it instead of trying to dissect next to the iliac vessels, the external iliac, or in the posterior for the broad ligament. So when you dissect on the psoas muscle, the planes and everything, you are much more confident in terms of, and the muscle provides a sturdier surface to dissect. So always I start from lateral to medial. So dissect the fascia, the peritoneum on the psoas muscle. You'll be able, so the incision has to go up till the round ligament. In the caudal end, in the cranial end, you have to come at least to the level of the common iliacs, because the same incision can be extended above when you're trying to do a paraortic. Okay. So here I'm showing you this dissection with regular instrument, that is bipolar and scissors only. Okay. We are not using any ultrasonic energy. So it's not that, oncosurgery would require always advanced bipolar or advanced instrumentation, or even for that matter, 3D camera systems. Though with 3D camera systems, depth perception is much more proper. The ease of doing surgery is much better. But my personal experience with long operating with 3D camera systems, your head tends to become much more heavier. Okay. And when you change your focus to the instrument trolley and back to the monitor, there is so start dissecting muscle up till the round end of the round ligament, the exit of the round ligament. That is where you stop. That is the external limit, caudal limit over here. So you're running parallel to the external iliac artery. You can see on the medial side, this is the left side dissection. The left side, you can see the psoas muscle. You can see small blood vessels as well as the lymphatics. In terms of lymphatics, again, I like to specify lymphatics, instead of shearing the lymphatics, it is better to seal and then excise. So a lot of, dissection can take place with suction irrigation cannula. But with suction irrigation cannula, the lymphatics tend to get sheared. And that is the reason your postoperative collection of lymph in a lot of patients. At least the thicker lymphatics you should seal and cut with whatever, bipolar, monopolar, or ultrasonic. So stay parallel to all the long structures, stay parallel to the muscle. Keep on dissecting. You can see the obturator nerve, which is on the deeper layer. Okay, on the medial side, you can see the external iliac vein and the artery. So the vein is posterior and medial to the artery. And you can see we have dissected the ureter already. This is in the medial leaf of the broad ligament. Okay. So unlike in Vardha MC, you tend to lateralize, and because of lateralize the ureter, so you can dissect the rectal space very nicely. Here in laparoscopic for endometrial cancer, you can retain the ureter in the medial fold of the broad ligament. Okay? Stay parallel to the blood vessels. See, the approach is from lateral to medial. So the muscle provides you a thicker surface to work on. Okay, so that you can go in between the planes of the external iliac artery, vein, and the muscle. Right? So you can use a Maryland type of bipolar, or you can use a regular one, which I am using. Sometimes the Maryland type of bipolar, if it is not blunt, it will poke the blood vessels and you can have injury because of it. So I prefer a blunt tipped bipolar in all my dissections in terms of malignancy also. To take on all the lymphatics, try and use the current, seal the lymphatics, at least the large ones, pull it, and in all oncosurgery, remember, as you can, if you remove the lymph nodes in a single bundle, it's much more easier to do that. If you have a large bundle, it's easier to strip. If you have smaller and smaller lymph nodes, again they slip with the grasper and it's difficult to grasp them again and again. Always send the lymph nodes separately in terms. So we send the left side lymphatic separately, the right side lymphatic separately, and obviously the parotic lymph nodes, if you're doing the supracaval, infracaval, both the lymph nodes set is sent separately. Okay. The frozen section details everything Anil is going to discuss. So in terms of significant lymph nodes, anything that appears big looks like significant in surgery. So you any lymph nodes whichever we find are very big, at least those lymph nodes we try to remove. Okay. So go from lateral to the medial approach. It is much more easier for anybody to emulate, and stay parallel to all the long things, that is the ureter as well as the internal and external iliac vessels. If an internal iliac shape is easy to seal, but an external iliac vein injury is very, very difficult to tackle. Things are very, very you should be very careful in terms of trying to remove it. Okay, otherwise you will have torrential bleeding, and then you would have problems. So external iliac is the area you should be careful, and again another region is the common iliac nodes, where the junction of external and internal iliac arteries would occur. So that is the site where you should be careful. So remove all the lymph nodes. In terms of obturator nodes, you should always stay above the vein. If you below the obturator vein, that is where again the bleeding occurs. Most obturator nodes are always above the nerve and lateral, usually if they are present on the obturator fascia. That is, you can use the obturator muscle and the fascia as a plane to remove all the blood vessels. This is the upper limit of the lymph nodes. And the external one, you try to strip it as a continuous this thing. So you can use the ultrasonic or the bipolar or the scissors. So grasp the lymph nodes lightly. You can see the lymphatics very clearly. If you have used an ICG, lymphatics are very clearly mapped, and only the sentinel or significant nodes which are eliminated by the ICG or methylene blue can be removed. Then go for the internal iliac lymph nodes. Run parallel to the vessels. If it's in your dissection or you are not getting sufficient space to dissect. But I feel the obliterated umbilical artery serves as a good direction marker for your surgery. So where you are trying to identify the internal iliac bundle also. So even in Vardines, if you are doing, we usually keep the uterine artery identified. We ligate the uterine artery, but don't cut it. Ureteric tunnel. Identify the ureteric tunnel. At least in Vardines, you should keep the artery as patent as possible. Okay? So go parallel to the vessel, seal the lymphatics, keep on using your scissors. I use suction cannula sometimes, but keep going, which is manipulated, it is very close to the field of vision. So in deep spaces, the idea is for you to get a clearer vision. So more the depth, more difficulty for you to operate in depth of the pelvis. So that is the reason why 3D camera system has come to improve the depth perception in all these cases. Okay, you can see the obturator nerve below now. So you can start from lateral to medial, and if required, you can go on the medial side again. Identify the bundle very clearly, the obturator bundle. You can see the lymphatics. You can use a sealer or a bipolar. Strip the lymph nodes. You can see the nerve now. So the relation nerve first, then the artery, and the last would be the vein. So that is the reason you should never ever go below the obturator vein. That is where most of the bleeding occurs. So in terms of the venous anatomy in pelvis, there is at least around 30 to 40% of venous abnormalities in pelvis. So you can have a lot of veins. Regularly you would be find as running parallel to the artery, so a lot of venous supply which is there, or neovascularization is there, so you should be careful in terms of those vessels. In terms of the vesical branch of the internal iliac also, you should know sometimes it can arise from the uterine artery also. So grasp the lymph node with the endoclinch or a regular bowel leading grasper, stay parallel to the structures. Way to strip. Clearly notes nicely, catch it as a bundle, then you can cut by bipolar and sealers to seal the lymphatics. The logic is sealing. See, if the patient has less lymphoria, post-operative treatment, if any required, that is the radiotherapy or the chemotherapy, can be started very early. So when you remove all the nodes, or you're not doing a sentinel lymph node mapping, a drain is mandatory in all these patients. Okay, I think this would cover the surgical part. The rest of the discussion, I think Dr. Sandra is going to discuss para-aortic lymph nodes and everything. Thank you, everyone. Thank you. Thank you.
Thank you, sir. Thank you. It was really very, very nice. Very easy to see. I know it is very difficult to do a pararectal and lymph node dissection. Very nice surgery, sir. So
Thank you.
moving on to next session, I would like to invite our third chairperson, Dr. Priya Ganesh Kumar. Priya Ganesh Kumar is a colposcopist and a gynecologist, and she is the Foxy Gynecological Oncology Committee chairperson, elect in 2021 and 23. Sorry. I would like to invite Dr. Priya Ganesh Kumar on the digital virtual dais, please, to introduce our third speaker, Dr. Sandra So.
Yeah, thank you very much, Dr. Rekha. And yes, talking about, and it's a very nice webinar going on. Many of the questions, I hope, like what all we have will be definitely answered. Of course, talking about endometrial cancer, it is quite low in India. The rates are around 4.3 per 100,000 women. And yes, high in Bangalore and Delhi as the stats shows, and in Mumbai it is little low. And about the robotic surgery, it's a very nice topic which has been selected. And robotic surgery definitely has a shorter operative duration. And when you compare it with the laparoscopy, there are a lot of trials which has been done, like LAP2 trials, LACE trials. And globally, you have a lot of literatures onto it. In India, the robotic surgeries, again, is becoming a common modality these days because there is not much of conversion to laparotomy whenever you talk about. If you compare it with the laparoscopy, because of the positional intolerances. And of course, there's not much of a difference when you compare with the rates of complications. So we have with us Dr. Sandra Suho. The topic which has been given is to her, and I know she's going to do a very good deliberation: robotic surgery, surgical steps, para-aortic lymph node excision, and advantages and morbidity. So she's going to talk about that, and she's going to highlight and let me tell a little bit of Dr. Suho. Miss San Suho is a subspecialist accredited gynecological oncology surgeon. She graduated from University of Birmingham, UK, and completed her general obstetrics and gynecology training in Newcastle and subspecialist in gynecological oncology in Pan Birmingham Gynecology Cancer Center. So there you are. Now, Dr. Ms. San Suho, we are all eager to hear from you. Over to you, Dr. San.
You're able to hear me all right now, yeah?
Yeah, we are
well,
here.
Thank you very much for the invite. So I'm going to concentrate very much on treatment of high-grade endometrial cancer, that is where lymph node dissection is going to have a role. And then go on to talk about robotic surgery, my experience with it, and a little bit about sentinel node, hopefully with some interesting video clips. So just a bit of background, endometrial cancer, most of them get detected in stage 1, early stage, and the incidence is definitely increasing, most likely probably due to the increase in obesity in the Western world and also an aging population. Now, again, concentrating on the high-grade type 2 endometrial cancer, that will include the grade 3 endometrioid and other subtypes like serous, clear cell, undifferentiated, or carcinosarcoma. So if you look at the incidence of endometrioid cancer, it's definitely going up, but the rest of the high-grade subtype is fairly static over the years. Now, type 2 tumor, they are a lot more aggressive. They can, as Dr. Rao previously mentioned, I've seen patients with picked up a high-grade serous carcinoma of the uterus only with the endometrial thickness of 2 millimeters. So they are very unpredictable. They are a lot more invasive, more aggressive, and therefore they can actually get picked up at more advanced stage of disease. So when patient diagnosed of endometrial cancer, they will usually get sent to us as a surgeon at the first instance, because surgery, hysterectomy will be the gold standard of treatment. But obviously when I see a patient, the first thing I ask myself is whether this patient is fit for surgery, especially if these patients are usually the patients that we deal with endometrial cancer, they're elderly, they have loads of comorbidity, a lot of them got diabetes as well, and they're obese. So really, I think before you put a patient through any surgical management, the first thing is to see whether they're actually fit for surgery. And also don't forget that there are alternative treatment like a hormone or radiotherapy if these patients are not suitable surgical candidate. So if they are suitable for surgery, what type of surgery you're going to do? Nowadays it's minimal access surgery, but there's still role for laparotomy, and sometimes, especially in more advanced stage, that you want to get a good margin for resection. Now, as a general rule in the United Kingdom, if the patients, they tend to be in low grade, just need a hysterectomy, BSO, they tend to be dealt with by general gynecologists with special interest in gynae-oncology, and they will just perform a hysterectomy, BSO. And for the high-grade cancer, they tend to get referred to a tertiary center where you've got subspecialist trained gynae-oncologists to be performing the surgery in the form of hysterectomy, BSO, with plus and minus pelvic node dissection. So going back to a bit of an evolution of how endometrial cancer has been treated. So in the past, it's all conventional laparotomy, and minimal access surgery came in and obviously showed that it's superior to laparotomy in terms of less blood loss, less hospital stay, less pain. And this is very well demonstrated in the LAP2 trial. And the subsequent data also show that the disease-free, the risk of recurrence and disease-free survival is comparable to laparotomy. And that makes minimal access acceptable way of dealing with endometrial without crossing from oncology point of view. So the question is, do we do lymphadenectomy, and who do we do it on? And again, that take back a little bit of background. If you look at lymph node spread, as I say, low risk endometrial cancer, the risk of lymph node metastasis is very, very small. For those intermediate group, you start creeping up to 5 to 10%. So it's very debatable over the intermediate risk group whether there's any role for lymph node dissection. And the high risk group, obviously, in more than 10% lymph node metastasis, there's definitely a role in lymphadenectomy. And also note that regardless how good an MRI and CT scan nowadays that we have, almost a quarter of patients will get upgraded following the hysterectomy, and your nodal status will not be known until after you have the surgery, following the fecal surgical staging. Now, going back to, again, a little bit basic, like Dr. Prashant previously mentioned, most of the uterine endometrial cancer, the lymph node spread is going to be in pelvis. So majority of them will go into the pelvic lymph nodes, the common iliac, external, internal. And if lower segment of the uterus, you can involve the presacral as well. But there's a very important point in uterine cancer, there's another mode of lymph node metastasis, which is from the fundus via the IP ligament. So they can actually have a negative lymph pelvic node with a positive para-aortic node. This is a very, very small percentage. So if you only about 3% or less will actually have negative pelvic nodes and positive para-aortic node. And this is very important in terms of how we're going to manage the patient clinically and has clinical implication. Now, also that patient with positive pelvic nodes, there may be good 50% risk of para-aortic node involvement, even if it's not shown on the staging CT scan. And this might have implication to our clinical oncologists, how they want to plan radiotherapy post-op with someone with pelvic node positive. They might want to extend the field to the para-aortic area, which Dr. So what is the evidence about pelvic node dissection? So that everybody probably quite familiarized with the MRC Aztec trial, randomized controlled trial involving 4 countries, 85 centers, looking at hysterectomy versus hysterectomy and pelvic node dissection. And it found that there's no survival benefit of performing pelvic node dissection. And again, the Italian Pacini et al., and this is quite a big randomized controlled trial again, concluded the same thing, saying that there's no survival benefit for pelvic lymphadenectomy. And that's confirmed by the Cochrane. Again, no evidence of pelvic lymphadenectomy actually increasing overall survival. And in fact, it actually increased the surgical related morbidity like lymphedema, lymphocyst formation. Now, so if there's this evidence against it, what is the evidence for para-aortic lymph node dissection, which is even more morbid? Now, the Japanese has done a trial, a simple study looking at patients who either have pelvic lymphadenectomy versus pelvic and para-aortic lymph node dissection. So they found that the overall survival is better in the group that have both pelvic and para-aortic node dissection. And also the Korean study also supported pelvic and para-aortic node dissection in high-risk endometrial cancer. So again, we're back to the dilemma with all these studies, to controversial study, to say whether there's any, do we do pelvic or do we do pelvic and para-aortic, or do some cancer centers will say, do we actually need to do pelvic node dissection at all? Now, I think very much from my experience, I do believe that I work very closely with my multidisciplinary team, and a lot of our treatment, surgical treatment, will rely on our belief by our clinical oncologists as well. So most of these patients will have gone through multidisciplinary team meeting, and they need to be tailoring and work with clinical oncologists to what's best for this group of patients. So our cancer center, I personally do believe that there's a role of pelvic node, lymph node dissection. And I think that lymph node dissection allows a complete surgical staging, because radiology staging has limitation, and you actually get microscopy, you actually get a proper surgical staging by performing lymphadenectomy. And that will help our clinical oncologist to decide whether this patient will benefit from radiotherapy or not, or whether you need to irradiate the entire pelvis, or whether you can just give a limited brachytherapy for a patient with negative node. So that will decrease the risk of morbidity from radiotherapy as well. Now, if there is some positive nodes metastasis, then potentially by removing the lymph nodes, you will be able to remove that metastasis as well. But bearing in mind, I don't think there's any study that actually confirm any therapeutic value of lymphadenectomy. But I have experience coming through a very bulky nodes. If they are very bulky, they sometimes, Dr. Banner can probably fill me in later on in the talk, they don't really always respond very well to chemoradiotherapy, in which case by debulking that bulky nodes, you may be able to control the local disease a bit better with adjuvant radiotherapy. Now, para-aortic node, because I routinely do for high-grade endometrial cancer, we routinely do pelvic lymph node dissection, as we know that if they're pelvic node positive, there's 50% risk of para-aortic node involvement, in which case a clinical oncologist sometimes will give extended field of radiotherapy. Then arguably you can say, why do you want to put the patient through more extensive surgery with para-aortic node dissection, and then on top of what our clinical oncology would have given them more radiotherapy above the field anyway. And para-aortic node involvement in completely isolated with negative node is extremely small. So I think you just have to get the balance right, because it's a lot longer surgery, a lot more risk of complication in this elderly lady. So it's not probably for all surgical candidates. And I think although we presented all the papers, those papers need to be interpreted quite carefully into details about the cohort, the age of the patients, and also the selection of the patients. Now, so as a general rule, I think most cancer centers in the UK, we recommend that we don't do routine lymphadenectomy for low-risk group. There may or may not be a role in intermediate group, and again, that will get tailored during a multidisciplinary team meeting. And for the high-risk group, as a general rule, we do pelvic lymphadenectomy, and we do not do para-aortic node dissection routinely. So I'll talk a bit more about robotic surgery. I'm sure a lot of surgeons here will be quite interested to know. So I've done robotic surgery for almost 4 years now, and I'd be delighted to share a little bit about robotic surgery. So the principle is very similar to minimal access surgery. The patient again needs to be in Trendelenburg, and just like minimal access, and because of lymph node dissection or more radical hysterectomy, they need to be in that for quite a length of time, and that is when you have to really work your patient out and find whether they are suitable for this kind of procedure. Now, this is the robotic machine that got docked to the patient, and then that is how you can appreciate the operating theatre need to be a fair size to accommodate this robot assistant and everybody, and the surgeon usually just sits on away from the patient at the console to be operating. So I find robot is really beneficial compared to two-stick surgery, especially with the length of surgery, complex surgery like node dissection right near the vessels. Raised BMI is a massive issue here. Very commonly we come across BMI of 40 or 50, and trying to do laparoscopic surgery is quite challenging in this patient. And robotic surgery allows that endo-risk maneuver with an instrument that two-stick surgery would not be able to. And the camera is great. You get very good vision. Hopefully I can demonstrate that in the video later. And obviously I control the camera. I control 3 arms. So I don't need to be asking the assistant to zoom in, zoom out, left and right. So I literally, control all these instruments. It does, after a long time doing two-stick surgery, you do get quite tired, and from surgeon's perspective, doing the robotic surgeries for 2 or 3 hours, you don't feel as tired. Now it's also very good for mentoring as well. There's some robot that come with a dual console, so you'll be able to sit next to your mentor, or you've got your trainee, that you'll be able to use a pointer to be able to just point them where to cut and what to do. So it's fairly good for training. Now this is my usual port placement. So the middle one is where the camera port goes into. I tend to say that every patient can be a little bit different. On average, I tend to put it about 2 to 3 centimeters above the umbilicus, because you needed quite a widespread view so that the robot will be able to dock, because it's quite a big machine. The general rule is the camera port should be 1 hand breadth above the fundus of uterus. So if you've got a very atrophic uterus, you want to put your camera port a little bit lower. But if you've got a very bulky uterus, you want to put 1 hand breadth above it. If not, your camera will be very, very close to it. Now this is an 8mm robotic ports. So you can see there's hinges here where the actual robot docked to. Now I tend to put this around about 3 centimeters above the anterior superior iliac spine, just so that you get quite a nice rounded port placement. And this middle port and the assistant port will be contact in between all these main 3 ports. So in a big lady, it's quite easy to get a linear kind of linear port placement. For a very slim lady, robot can be more difficult. So you tend to do what we call like an inverted M shape, so that you'll be able to, so that the port placements does not clash with each other. So the robotic in gynecology surgery, because the legs is up, because we tend to put uterine manipulator and the specimen got retrieved from down below with the assistant, we tend to do what we call lateral docking. So the robot would tend to come either from left or right side of the patient, and then come close to here, and all these 4 arms get docked into the ports that I show you. Now these are the instrument and the wrist, so they get fixed straight into all these 4 ports into the abdominal cavity. And this is the just a view of how the inside instrument will look like. Later on in the video, you should be able to see how this instrument kind of rotates. This is at the end of just how the whole robot being docked and how the operating table will look like. So now I'll show you a video clip. Dr. Prashant has shown pelvic node dissection already, so I'm just very quickly going to demonstrate how it looks different in the robot, and I'll just have to fast forward into the right clips for some of this. So you can see again that was the round ligament open, and then this is the pelvic sidewall, and this is a bipolar Maryland that we use with the robot, a Pro grasper, and I use monopolar scissors. And very nicely that you expose. This is again very nice clear 3D views you can appreciate, and sometimes you can even see blood cells like flowing in the capillaries or in those vessels to that extent. So again, very similar to what Dr. Prashant said, you got the external iliac. I tend to start from, again, psoas muscle there as like boundary as well. And I use very similar approach to him. I go a lateral approach to go straight into the obturator fossa. So I'll just fast forward that a little bit. So you can see the genital femoral nerve there. Again, this can get affected during lymphadenectomy, and patient can get like numbness in the inner thigh, which I always warn them as part of the consent procedure. And you can see that is external iliac artery and vein. And so I say just try to get into the right plane to harvest all these lymph nodes on block so that they don't come in pieces, but it's sometimes easier said than done. Sorry. So again, the boundary of your medial, your ureter or your obliterated umbilical. So that is your external lymph glands harvested, and you have to be extremely careful with the external iliac vein because they're very collapsed because the patient's on Trendelenburg, so it can be very easily injured during node dissection. So I'll fast forward into the obturator fossa. That is the bony structure there. As you can see below that, we'll go into the obturator fossa. And like Dr. Prashant said, that our boundary is at the obturator nerve, and we don't usually need to go beyond that. Because beyond that, you're going to have a lot of vessels. So again, you can see that is the obturator fossa, and you can see the obturator nerve there, and there are loads of horizontal veins feeding through. So usually that is our boundary. I think in this case we've gone slightly lower than that, but that will be how the pelvis will look like at the end of the dissection. Right, so if I move on to the parietal node dissection. So again, you open the retroperitoneal space. There are a couple of ways of doing some surgery just go straight in opening the retroperitoneal the peritoneal space along the vessels and just follow it. some will actually dissect it from ascending colon and slightly like a Z shape transversely, where you will see duodenum horizontally, where you need to kind of cauterize to reach the renal vein, and also on the descending colon mesentery. So again, this is using bipolar Maryland, sealing that lymphatics, and then monopolar scissors. Now, we will keep going, and hopefully we'll be able to see. And that is the ureter on the right-hand side, because it's very close. I think it's coming out. That's what they're trying to identify. But they can see, appreciate that is the bifurcation of the common dam. You can see the bifurcation. You want to harvest all the lymph nodes in the middle and on either side of the aorta and IVC. So everybody probably familiarized that IMA will be the only anterior branch on the aorta. So again, this is as they gradually work your way up, and then that will be the IMA and harvesting all this. And also the lymph glands in between the IVC and the aorta. And hopefully, so you get a quite good overview. You can see, appreciate it's a bit darker, but there's the IMA. It's all being stripped and IVC, and then the bifurcation of the common islet there. So I'll talk about a bit about sentinel node. So sentinel node is the first lymph nodes that cancer is likely to travel to. So it's quite well established in breast cancer, melanoma, vulvar cancer as well. A lot of cancer center actually do on uterine cancer as well. The agent that you can use, like Dr. Prashant previously mentioned, is technetium-99, and then you can use a gamma probe to try to detect where the sentinel node is. Blue dye has been used. Sometimes some centers will use a combination of two different agents, and green dye is the more kind of modern, a very common one to be used, and it's very pretty actually when you look under the microscope. So the ICG. So the injection technique is another one. A lot of single institutional will to explain their experience about sentinel node and different technique. Most of them are cervical injection using a spinal needle at 3 and 9 o'clock, and then 10 minutes later, hopefully you'll be able to see it on the with the ICG fluorescent. So it is not always very straightforward. I think it's an experience of a cancer center. At the beginning, is a lot of optimization in terms of depth of injection, the dilution, because it's not just like it comes in a syringe. ICG needs to be diluted, and some people find that you get, if you put too much, you get overspill of the ICG. You put too little, you get negative mapping. And sometimes we always say that some patients probably have lots of multiple loop before, or they have difficult negative mapping. And as a general rule, the RCOG recommend that if you get negative mapping on that particular site of sentinel lymph node, you need to do a full lymphadenectomy on that side. And there's also been reported that there's no node found in the sample, and that you know, when it's sent to a lab, then you realize that there's no lymph node there. So essentially, you're not assessing the lymph nodes. So that become a problem, a dilemma as well. Now, this is Senti Endo is a report from.
Yeah, you've got 20 minutes.
Okay, I'll just show the last video, okay, in the French center. So they show quite good detection rate and also negative rate of false negative. And they show the benefit of ultrasaging in sentinel lymph nodes can pick up even more metastasis. So very quickly, I'll just end this with a video. So sentinel node, there's an ICG that you'll be able to click into the ICG mode, and you can see there's some even ICG dyes spill onto the fallopian tube and here, but this is very nicely demonstrating on that channel into the lymph node. So endometrial cancer, you're going to have your on both sides, one on the left and on the right. And when I mentioned about the periodic spread with negative node, I think that is something that you just have to bear in mind. Okay, so again, you can keep switching between the normal mode and the ICG mode and opening the sidewall, trying to identify this particular node. And let me see. So again, you can keep switching until you actually make sure that you're getting the right node, and that will be it. So that is a center node, and then remove in the back, keep it separate, and then the same repeat on the other side. Okay, thank you.
Thank you, Dr. Sandra. It was wonderful. To be very frank, I am watching this robotic surgery for the first time and really, really fascinated. Thank you for your talk. Now, hello, Mrunali.
Ma'am.
Yeah, is Dr. Chavan online?
Yes, he's there, Dr.
Yeah.
So
Hi.
now we are move on to fourth session. I would like to invite our fourth chairperson, Dr. Niranjan Chauhan, who's a professor and head of unit in Municipal Medical College in Mumbai. And over to you, Dr. Niranjan Chauhan. I'd like to invite our fourth speaker, Dr. Rajni Bhana.
Thank you, Dr. Rekha. It is a pleasure to come to Thane Obstetrics and Gynecological Society, and I see Dr. Rajiv Lowell sir and Datta Panandekar, who are at the helm of affairs doing a wonderful job. And I'm honored today to hear Dr. Sandra Soho presentation just before my chairperson presentation starts now. Wonderful lecture, madam. I'm really thrilled about it, and it's so great to hear. Now I have the opportunity to welcome Dr. Rajni Bana. I request you to please show the slide of her CV so that I can read it, and then we will go ahead with madam's presentation.
Yeah, I'll just do that.
Yes, madam.
Yeah. Share.
In the meantime, I would request you and appeal you with the permission of the President and Secretary that do exercise your right and your vote, and endoscopy for every gynecologist, endoscopy for all. Please do vote for me in the upcoming elections, October 1st to 15 for IAG Treasurer's post. Thank you so much, Dr. Rajiv Lowell, to give me this opportunity. Dr. Rajni Bhana is MBBS, MRCP and FRCR, PG certified, did her undergraduate medical training in Johannesburg. After coming to the UK, she has completed her foundation medical and specialist clinical oncology posts and training. Her main interest is gynae brachytherapy and in cervical cancer. She is a consultant level experience for more than 12 years. She is currently implementing the Space OAR service and supporting implementation of SABR for lung cancer and oligometastasis. She is also a core member of both gynecology and urology, oncology, multidisciplinary teams and a key management decision maker. Presently, she is the clinical lead for oncology department of UHNM. I call upon her to present her case. Thank you. She will be talking on brachytherapy and radiotherapy today.
Rajni, can't hear you.
Hello,
Rajni?
can you hear me
Yes,
now?
now I can hear you. Yeah, now we can
Yes,
hear you.
yes.
Good afternoon, everyone. Thank you, Dr. Shaban, for that kind introduction. Thank you to Thane Obs and Gynae Society for this invitation. And it's a real pleasure and a privilege to be part of this wonderful panel of speakers, and a big sort of act to follow, you know, after those wonderful surgical presentations. I've learned so much. But my role today is really to talk about the non-surgical management of endometrial cancer. I am a clinical oncologist, and in the UK, I am dual accredited for radiation and chemotherapy. Could you change the slide, please? Okay, so the objectives of my talk is really to give you a bit of background, and you've had a lot of background already, so I won't spend too much time on that. But then to talk about radiotherapy, to talk about external beam radiotherapy, vaginal brachytherapy, and to talk a little bit about systemic anti-cancer therapies, and then look at the controversies that are existing at the moment for patients with gynae malignancy. So as you've heard, it's the commonest gynecological malignancy, and worldwide, there's about over 380,000 women with endometrial cancer. It is certainly a disease of lifestyle, and in particular, the risk factors are that of obesity. And we commonly in the UK get patients who require bariatric surgery, who have a BMI over 50, and they produce a lot of additional treatment challenges. There is about 5% of gynecological malignancies which are linked to a genetic abnormality called Lynch syndrome, type 2, and they too will have other hereditary non-polyposis colorectal carcinomas, and as Mr. Raut said earlier, there is a link with ovarian cancer as well. So you would be familiar with all of this, but just to say, we've heard a lot about this Bachman dualistic classification, where endometrial cancers have been divided into type 1 and type 2, estrogen dependent and non-estrogen dependent, endometrioid and non-endometrioid histologies. And of the type 2, the prototype is the serous papillary cancer. But this classification is now being challenged with molecular classifications and greater knowledge of genetics. And I'll come to that in a bit. So prognostic factors, stage obviously is a major prognostic indicator, and therefore comprehensive surgical staging may not in some cases change outcomes in terms of overall survival, progression-free survival, but it does give us tremendous amount of information regarding prognosis. And when we then speak to our patients, we can have a more open and honest discussion regarding prognosis. And if you look at stage, you know, just pelvic lymph nodes versus para-aortic lymph glands in stage 3, C1 and C2, there's a big difference in survival. Grade 3 depth of invasion greater than 50%, and the presence of LVSI, not even positive lymph nodes, just the presence of unequivocal LVSI will have a big impact on patients' survival. And then endometrioid cancers naturally will do better than clear cell carcinomas and serous papillary cancers. So we've been through the figure stage. I won't spend too much time on this. But looking at this newer classification, you know, with new information, particularly this last few years, there is something called the POLE mutation, which is part of this commonly in endometrioid cancers. This microsatellite instability high, which is linked to mismatched repair genes. And then we've got other types of mutations where the copy number high would be probably linked to P53. Now, routinely in most centers, we're not doing all these molecular testing. Most of them are done via immunohistochemistry. Some of them are less well available and more expensive. And I think we do have a pathologist on the panel later, and perhaps he can explore some of these issues as well. But essentially, with those mutations, regardless of the morphological but subtype, and regardless of whether they're estrogen dependent or independent, these will affect prognosis quite significantly. So in our center, we have a very, very well functional multidisciplinary team meeting. You've heard about the key core members in the team, and we try and stick with evidence-based and guideline-based approach. Surgery is still the mainstay of treatment. Whether you do that open surgery, obviously there's more evidence now versus minimally invasive techniques, laparoscopic and robotic surgery, whether you do pelvic or para-aortic node, surgery is still the mainstay of treatment. And then obviously sentinel node guided biopsies now are becoming more of a feature. So with radiotherapy, there's different types of radiotherapy. And I'm going to use this slide really to kind of give you some of the evidence based on the risk categorization. So when we look at low risk ovarian endometrial cancer, they make up the majority of the patients we see. So these are stage 1A, grade 1, grade 2 endometrioid histology, and these are treated with surgery alone. There was a trial in 2009, it's a randomized controlled trial, which looked at vaginal brachytherapy alone versus observation in patients with post-surgery. And there was really no difference between giving brachytherapy and doing nothing. So we do nothing. So after surgery, these patients are often discharged from follow-up, and they have open access to the team if they have problems. And we'll go through what the red flag symptoms would be, recurrent bleeding, unexplained weight loss, and so on. Intermediate risk patients, again, there's clear strategy for these patients, and they make up about 30% of our patients. And these will still be endometrioid, endometrial histology. There'll be grade 3 histology, and some patients will have deep myometrial invasion. And in this, it's also been very well investigated, and there have been large randomized control trials, the PORTEC-1, the GOG-99, and the ASTEC trial, which actually looked at external beam pelvic radiotherapy. And that's been found to reduce locoregional recurrence, but has no overall survival advantage. And the reason for that was that those patients who recurred locoregionally were able to have salvage radiotherapy plus or minus chemotherapy at a later date. So we were able to then improve their survival in that way. And then more recently, the PORTEC-2 trial looked specifically at external beam pelvic radiotherapy and vaginal brachytherapy, and there was no difference in outcomes between those two treatment modalities, but vaginal vault brachytherapy was better in terms of toxicity. So for a patient with intermediate risk cancer, I would offer vaginal brachytherapy alone without external beam radiotherapy. These patients we often discuss in MDT. Is there LVSI? Is it unequivocal? Is there extensive LVSI? Has the patient had lymph node sampling? And that will then also determine whether I then decide to give external beam rather than brachytherapy alone. And the high risk group, this is kind of the group that really needs a tri-modality approach, to get good long-term outcomes. So that's the surgery with adjuvant radiotherapy and possibly chemotherapy. And they make up about 15% of all the patients we see. So in this group, we're looking at the grade 3 muscle, deep myometrial invasive endometrioid, but we're also looking at that non-endometrioid histologies. We're looking at serous carcinomas, clear cells, the carcinosarcomas, and we're looking at stage 2, 3, and possibly even 4A disease. Now, looking at radiotherapy schedules, when I give vaginal brachytherapy alone, we give 21 grays in 3 fractions, so that's 7 gray per fraction. And in our center, I run the gynae brachy on Tuesdays and Thursdays. So if I treat these patients over 2 weeks, they'll have a session Tuesday, 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 or Tuesday, Thursday, Thursday, or whatever combination, depending on availability. But it's really over a couple of weeks. When I combine the brachytherapy with external beam, they don't need as much dose as the 21 gray in 3 fractions, and we give between 8 and 10 gray in a couple of fractions, and that's sequential after the external beam. Now, for the pelvic external beam alone, we use volumetric arc therapy. Now, this is one of the most advanced and modern types of radiotherapy, external beam. And we give a dose of 46 gray in 23 fractions, treating daily. And the treatment then takes about 5 weeks. And if I treat someone with para-aortic, again, if there's a high chance that they have para-aortic metastasis, micrometastatic disease, if they've got quite extensive nodal positive sample in the pelvis, then I will treat this effectively. I'm not talking really about palliative radiotherapy, because again, radiotherapy dose is very important for palliation for some of these patients with inoperable disease, where they have bleeding and pelvic pain. And what we also can do with this modern volumetric arc radiotherapy, if there is a lymph gland that was as enlarged or was not able to, reach during surgery, then I can give a simultaneous integrated boost. So I can treat the pelvis with that particular lymph gland. And it will then be helpful, to discuss that with the surgical colleagues, and if they can then put a metal clip, which will then be seen on CT scan, and I'll use that as what we call a fiducial marker to be able to boost that lymph gland. So this is a patient who's had 2 arcs of radiotherapy. We've come a long way with external beam. When I became a consultant, we were using orthogonal films, sort of magnified X-rays, and actually drawing on the patient's X-ray and then creating lead blocks. Then we went to CT scanned and planned radiotherapy. And initially it was using bony landmarks, what we called virtual simulation, and we've gone one step further using conformal radiotherapy, where we're actually outlining the areas where we want to treat. And further still, we went to 4-field radiotherapy versus sometimes 7 and 9-field intensity modulated radiotherapy. And now we've got this volumetric arc radiotherapy, where the linear accelerator just continuously goes around the patient, giving this radiotherapy. And we have what we call multi-leaf collimators, which are then shaping and conforming the dose of radiation very, very well. And with this type of radiation, we can actually sort of shape it around things like the bladder and the rectum to reduce the toxicity in those areas. This is the vaginal brachytherapy set. It's a very simple set. Again, depending on the patient's anatomy, for some patients who maybe have had previous children, we could use about a 3.5 centimeter diameter vaginal applicator. And for some patients who've perhaps never had children before, nulliparous, or we can use a much smaller. And again, the size, the length of the vagina will differ in women. And this will be then the dose distribution, where we get a very, very high dose to the vaginal mucosa. We usually treat about a third, the upper third or upper half of the vagina with brachytherapy. And when we use external beam, that I want to treat the upper third or half of the vagina. I'd like to treat the paravaginal tissue, the vaginal cuff. We treat the internal, external, and common iliac nodes. If there is positive nodes in the common iliac, then I'll go to the para-aortic. And if there's a positive node in the para-aortic, then I want to treat about 2 centimeters above that para-aortic node. So this is my brachy suite in the cancer center. We have 4 linear accelerators in our center, and we use a high dose rate brachytherapy. So this is what we call an afterloader. So there is no handling of active radiotherapy. This is high dose radiotherapy. We treat patients, we don't do overnight stays, so all patients are treated as day patients, and they go home the same day. There's no real preparation required for brachytherapy. There's no anesthetic, no regular analgesics, and no sort of preparation of any sort required. So it's a very simple, very well tolerated, very well researched method of boosting the vaginal vault. And that's, my team. And that's one of our brachyphysicists, and that's my consultant clinical oncologist over there as well. So looking at now some of the evidence for the radiotherapy, the PORTEC-3 trial, which was published last year, it was led by a Dutch patients with high risk stage 1 endometrioid cancer, looking at stage 2s and 3s and looking at more of the higher risk histology. And in this trial, 25% of the patients had the higher risk histology. And what this looked at is concurrent chemotherapy and radiotherapy followed by sequential chemotherapy. So 5 weeks of pelvic radiotherapy with cisplatin on week 1 and week 4, and then followed by 4 cycles of carboplatin and paclitaxel chemotherapy. And this is really fantastic data. It looked at the intention to treat population, so that's all people in the trial, and then it did sub-analysis looking at stage. And this is unsurprising, but if you look at all patients, the absolute value in addition to the chemorad was about 5% for the experimental arm compared to radiotherapy, which was the standard arm. And that's for overall survival, and for failure-free survival, it was 7%. But when you look at a deeper dive into the stages, really patients for stage 1 and 2, even though they had high risk features, really didn't gain much from the addition of chemotherapy, with hazard ratios of 0.83, 0.86, and p-values not really quite statistically significant. But when you look at the stage 3 population, and that's the population that really needs intensive treatment even after surgery, and if you look at the high risk, the addition of chemoradiotherapy and sequential chemotherapy alone is 19%. So that's a huge benefit to surgery alone. What they also did in this trial was look at there was translational research. So looked at the molecular classification, but they also looked at the cancer genome atlas. And that's really giving us so much more information, which is going to enable us to tailor and really individualize treatments. This was only published last month in the Journal of Oncology. So this was the same patients that went into PORTEC 3. From the 600 patients in the PORTEC 3, they looked at translational research in 410. And it looks like patients with this POL-E mutation, it was only 13% of the entire cohort, but they had the best prognosis. So regardless of the high risk features and regardless of the stage, 98% of these patients were alive and recurrence free at 5 years. And that is really fantastic. And they looked at the patients who are P53 positive, and they did overall worse in terms of 5-year prognosis, with more than half of those patients not alive. But the absolute benefit from chemotherapy to radiotherapy was 22%. Now that is, just quite amazing. And then there were the other, so the MMRD group, so that's mismatched repair genes, and then non-specific mutational abnormalities there. So if you look at the Kaplan-Meier graph, where blue is this POL-E mutation, and it's almost a straight line, so these patients have got almost 100% 5-year survival. And when you look at the P53 on the Kaplan-Meier graph at 5 years, you can see that it's sort of just below 50% over there. So these additional data is really setting a new trend in terms of how we actually starting to manage these patients. And it's about having a discussion now with our pathologists, having a discussion with our clinical geneticists, so we can actually grade and classify these patients differently. So there are going to be a few new trials coming up, looking at those mutations, looking at all stages, and then looking at additional novel agents like PARP inhibitors, which we're already using routinely in ovarian cancer patients, looking at immunotherapy, looking at hormonal therapy, which we use quite often, but not in the adjuvant setting space, and then perhaps looking at no adjuvant treatment, even in patients with higher risk histologies and higher stage disease if they have this POL-E mutation. This was another trial looking at, it was published last year in JCO, Journal of Clinical Oncology, and this looked again at the high to intermediate risk patients at stage 1 to 2, and they also looked at the higher risk histologies. And basically what they were testing here was whether external beam radiotherapy was better or worse than chemotherapy and vaginal brachytherapy alone. And in fact, there was no difference to the addition of additional chemotherapy and brachytherapy alone. But they did find that in the chemo and the brachytherapy alone, there were more pelvic and para-aortic recurrences. So really, for patients with early stage 1 and 2, high to intermediate risk, even higher histologies, pelvic radiotherapy alone should remain the standard of care. Now the GOG 258 study looked at higher stage disease compared to the previous trial. This was also published last year. And what this looked at is the same schedule that the PORTEC 3 looked at, concurrent cisplatin with pelvic radiotherapy followed by 4 cycles of platinum Taxol chemotherapy versus chemotherapy alone. And this also showed that there was no difference between the groups, but that by not giving radiotherapy, you increase the risk of vaginal, pelvic, and even para-aortic recurrences. So radiotherapy is a vital part in management for these patients, and chemotherapy should only be selected in patients with specific molecular genetic mutations. So when we look at chemotherapy, it's still platinum-based chemotherapy. It's still about making a decision based on the patient's risk, based on histology, based on stage, but also based on comorbidity. So that patient selection is vital Some of these patients are quite elderly, quite comorbid. They've got a lot of polypharmacy. So when we're giving them chemotherapy, we've also got to take a lot of those things into account. And at the moment, there's no standard of care for chemotherapy in the second-line setting. We've heard about the use of medroxyprogesterone and other hormonal agents. We use a lot of aromatase inhibitors like letrozole in the metastatic and recurrent space, but adjuvantly there's no licensed indication. So there's been other chemotherapies tested, but it's really the combination of paclitaxel and carboplatin. This trial was presented a week ago at the European Society of Medical Oncology conference, ESMO. And this was the first trial to test a drug called palbociclib. Now, palbociclib is a CDK4, CDK6 inhibitor, and it's commonly used in patients with metastasis.
Yeah, we have crossed 23 minutes.
Oh, sorry, I was waiting for your 2-minute, but I won't take too much longer. So really looking at newer agents, serous carcinoma, again, it's a separate, very aggressive entity, and there's a lot of other drugs being tested, like immunotherapy, like HER2, and biological agents against vascular endothelial growth factor. So follow-up has been kind of disrupted with COVID. We haven't even spoken about COVID, and we've gone very quickly to telemedicine, doing a lot of telephone consultations and video conferencing for routine patients. So in conclusion, there are a lot of controversies, and I can see with surgery, there's a lot of controversies, but there's so much improvements from surgery, from the different techniques, from radiotherapy, external beam radiotherapy, brachytherapy, and now chemotherapy. A lot of new data using all these genetic biomarkers, molecular biomarkers, new data in selecting patients adjuvantly for chemoradiotherapy, and new data in the management of the non-endometrioid endometrial histologies. So I'd like to thank you for your attention and participation, and that's the end of my talk.
Thank you, Dr. Rajni Bana. It was really wonderful and very elaborated talk about the radiotherapy. And now we'll move on to our panel discussion. Yeah. So our panelists are Dr. Nitish Rao, Dr. Prashant Bhamre, Dr. Sandra Soho, and Dr. Rajni Bana, and along with them, Dr. Anil Ramdas. Dr. Anil Ramdas is a pathologist. He has done his MBBS from Grand Medical College and post-graduation from Tata Memorial Hospital, Mumbai. He has in private practice since last 20 years. He's doing a frozen section for more than 15 years. He's a freelancing frozen section diagnosis with his own equipment and catering to many hospitals in Thane and Mumbai. So I welcome all panelists, and we'll start. Am I audible? We'll start all panel discussion. To Dr. Anil Ramdas. Can pathologists comment on myometrial invasion as well as on the significant lymph node on frozen section?
Hello?
Hello? Yes.
Yeah, hello. Am I audible? Yeah.
Yes.
Yeah, ma'am, absolutely. We can definitely comment on myometrial invasion on frozen section, and it is quite accurate as far as the depth, commenting among the depth of myometrial in most of the cases, almost 100% of the cases. So depth of the invasion on that is normally why we get a frozen section done in a case of CA endometrium. and the accuracy is very high, almost to the as good as 100%. That's it. As far as lymph node dissection is concerned, we do get the requirement for frozen session for pelvic lymphadenopathy, where the nodes are subjected to for frozen session, and the rates. They're way. If you report something as a positive metastatic lymph node, it's going to be a positive one for histopathology. The only thing is that there are a few chances that you might miss a micrometastasis or a very minimal, a few cells in the subcapsular location that can be missed on frozen sessions. Otherwise, as far as the accuracy and dependability of frozen session is concerned, it is definitely good, 100%.
You have to unmute yourself, Dr. Rekha. Dr. Rekha, unmute yourself.
Yes, yes, yes. Yeah. Now this question is for Dr. Nitish Raut. Has sonosalpingography any role to play in a diagnosis of CA endometrium?
At the moment, we don't do that, but basically if you're able to do the hysteroscopy under a local anesthesia, that kind of eliminates the need for having a sonosalpingography. Because of increased sensitivity of the hysteroscopy to be able to identify the polyps, any pathology, have a better visualization of neovascularization, any necrotic tissue. So it used to be quite useful, but with the thinning of the hysteroscopes, it's become hysteroscopy is more reliable.
Okay, and along with this, another query is that if it is a CA endometrium, with this fluid which we inject for the hysterosalpingography, does it give a spillage in the peritoneal fluid, peritoneum, spillage of endometrium?
Not really, no, because even we do that for hysteroscopy as well. There is fluid that goes through the fallopian tubes into the peritoneum. So answer is no, it doesn't, because it's connected to the what you call endometrium. So no.
Okay. So another question is to you, sir, again. Do you think that all patients who undergo hysterectomy for benign indications like AUB, should we do a preoperative endometrial sampling for all, either with the DNC or hysteroscopic guided biopsy?
That's a very valid question, and it's quite relevant to the routine practice as well. So I think in one of the slides I mentioned that anybody who's more than 40 years of age with irregular PV bleeding, definitely yes. Anybody more than 45 with heavy or any problems, yes. Anybody less than 40 but with a high risk category, either obese, then yes, basically. But if you're doing it for say, sorry, what are you saying?
No, if it is high risk, then only we should go ahead, not for
or more than 40 with irregular PV bleeding.
Okay. Next. Okay, there is a question from the delegates that can we combine hysteroscopic resection with progestin therapy in fertility sparing treatment, which is better, metroxyprogesterone acetate or IUD, that is hormonal IUD for progestin therapy? This question is open for all panelists. Anybody can answer.
Sandra?
Well, I think they both have been used in the UK. I think because the Mirena is, but if someone is confirmed, probably the proper licensed dose will be medroxyprogesterone, because you want a high enough dose to be able to kind of control or actually treat this. And furthermore, for fertility sparing is only a short term. Now, I think there are some data that Mirena coil will be suitable as well, but again, it will be a slight dose, but it's more kind of focused intrauterine. For my patient, I tend to prefer medroxyprogesterone in those cases.
One of the advantage that's seen with Mirena is better patient compliance. They don't have to bother to take the pill every single day. So, but we can't really guarantee that high dose with Mirena. So yes, that's it.
I think, to be fair, regardless of what hormonal treatment is being done, this patient, you still need to be in close follow-up. Symptoms is going to tell you whether she responds or not. Usually, if they responded, the bleeding will settle. And so if someone's continuing to bleed regardless of, you know, whatever treatment that you give, then I think you need to kind of revisit the whole situation again, making sure that the person is not progressing. And like Mr. Rao mentioned, that we do tend to want to resample, and sometimes we re-image as well, just to make sure that the disease is still confined, it hasn't spread anywhere, and things are not progressing, and it's actually stable or regressing.
Okay, so next question is to Dr. Anil Ramdas again. If curettage material is negative for malignancy and a hysterectomy is done, will it be necessary to do frozen section of hysterectomy sample? Dr. Anil?
Yes, ma'am. Yeah. We receive samples for of TMC curettage for which are in which we subject them to for frozen section, and the question I guess is if after the hysterectomy, if the report of frozen section is negative, and if the hysterectomy is done again, do we require to do frozen session on the hysterectomy sample also? The answer to this will be yes. So I advise them to do. I would like to do a frozen session, the examination on the hysterectomy specimen. The reason being that sometimes you may miss an early grade 1 adenocarcinoma on a DNC material or on an endometrial biopsy. So to be doubly sure about that, yes, I will advise that to be done. Over to you, ma'am.
You'll have to unmute you.
Now this
Hello?
question. Hello.
Yeah.
Yeah, for Dr. Prashant Bhambre, on table if we found the abdominopelvic metastasis, so what to do?
Depending on table, if you find metastasis, I think a consent, usually ultrasound and most of the investigations do pick up lymph nodes. And as Nitesh said, depending on the risk factors, you should thoroughly investigate the patient. So it is very rare for you to find, on table large lymph nodes which are not seen on CT or MRI or on ultrasound is very rare too. But at least the significant nodes or so-called significant which are larger in size, those at least to excise, and probably if available, do a frozen section in this patient. Okay. I think that is the right call than trying to do a complete pelvic lymphadenectomy or a para-aortic lymphadenectomy just because you have 1 or 2 nodes which are very big.
Next question is to Dr. Nitish Rao. Is there any genetic correlation between CA breast and CA endometrium? And does it run in family? That is CA endometrium, does it run in family?
The CA endometrium per se does not run in family, but except for the Lynch syndrome, the one that I mentioned, hereditary non-polyposis colorectal cancer, which has got a higher incidence. But the risk factors can have an environmental impact, like the obesity, nulliparity. These can influence a patient can be high risk because of genetic factors, but the CA endometrium per se does not run in families. No.
Okay. Next question is for Dr. Sandra So. Can you comment about the sentinel versus systemic pelvic lymphadenectomy? Is it only sentinel lymph node is enough, or we require a systemic pelvic lymphadenectomy?
Right, that's exactly what we're talking about. The systematic pelvic lymphadenectomy is quite a radical surgery, and it comes with a lot of risk of nerve and vessel damage, and also the risk of lymphocyte lymphedema later on following the procedure. So the beauty about sentinel node is to be able to know the nodal status of the potential first lymph node that will get drained from the uterine cancer. So if that node is actually negative, then theoretically the rest of the lymph node in the same lymphatic channel and above the chain should be negative, and that is working on that assumption. Therefore, sentinel node, hopefully in future, and with the benefit of just removing and up doing less radical surgery rather than putting a patient through systematic pelvic lymphadenectomy. So it depends. At the moment, it's not kind of widespread using as a standard way of treating in every cancer center, but most cancer centers, if they have experience, they are reporting their own individual cancer centers experience on the sentinel node, making sure that the sentinel node is accurate enough and there's no positive node kind of beyond that. Does that answer the question? Yeah.
Yes. So next question is to Dr. Prashant Bhamre. So what is your take on laparoscopic approach versus conventional open approach?
Endometrial cancer,
Yes.
I think we discussed already. None of us have mentioned open surgery until now. So I think endometrial cancers, I think definitely laparoscopy is the way out. Because as it is here, as discussed in the current trend, what is happening is, you might require radiochemotherapy. Laparoscopy is an added advantage in terms of, starting chemo radio if required in all kind of patients. And secondly, the magnification itself gives you a very good way to go about the lymph nodes and lymphatics. In open surgery, I was also in Tata. We tend to, share everything out, and there is so much of lymphoria post-operatively. So you have a drain which, which is active for 14 days or a month also in some patients, with all kind of lymphedema in the legs and the vulval area and everywhere. So I think laparoscopy, wherein you have good sealers and you are slow, you take each and every lymphatics and do it properly. I think for endometrial cancer, at least early cancers, operable cancers, definitely laparoscopy is the way out.
Okay. Next question is to again Dr. Sandra. I think you have covered this in your talk, but again I would like to and ask you this question: does parabolic lymph node sampling or excision really helpful in a management of, as a morbidity surely will increase because of this?
Yeah, this is a very morbid procedure with parietic lymph node dissection. I've seen things gone wrong. I've seen vessel injury. I've seen chylicystitis following a lymphatic channel that is obviously either not sealed off and reopened. I've seen severe kind of hydronephrosis because of lymphocyst pressing on the ureter. So as I say, in the UK, at least I can say that we don't routinely do parietic lymph node dissection for endometrial cancer, and for all the reasons that I previously mentioned in the talk, but we do pelvic lymph node dissection for high-grade cancer. And Dr. Banner, I'm sure she'll fill me in if the pelvic nodes, as I say, if it's positive, then she may consider a higher radiation field for the parietic node area because of increased risk of 50% chance of parietic node involvement. And therefore, my argument would be, why put the patient through a longer procedure in that Trendelenburg that everybody can see, and in elderly lady for a longer procedure with all the comorbidity, where we got our multidisciplined other specialty that will be able to treat this patient fully.
Okay, so next question is for Dr. Rajni Bhavna. What are the side effects of chemotherapy and radiotherapy?
Yeah, so it really depends where you're treating. So the common side effects of chemotherapy, and I'll just focus on this combination of carboplatin and paclitaxel. So things that occur commonly will be things like nausea and vomiting, loss of appetite, loss of taste. Patients with the paclitaxel will have alopecia, so they'll lose their hair temporarily. The hair will come back, but the effect on the immune system, so the myelosuppression, increased risk of infection, anemia, bruising and bleeding. Sometimes infection can be life-threatening, but with the right support, you can get these patients through treatment. The main thing about chemotherapy as well is the peripheral neuropathy. And we find that in studies, it shows that at about 6 months, patients' quality of life and physical functioning have gone down. But at about 12 months to 2 years, it may improve. So for some of these patients who may be still working, you know, it can impact on their day-to-day activities of life. And it can affect your liver, it can affect your kidneys. So it can affect, you know, the whole body. But we find with supportive medication upfront, we can manage the toxicity very well. In our cancer center, we've got an emergency admissions portal. So any patient who has any toxicity from chemotherapy can ring a 24-hour helpline. If they need to come in for assessment, they'll come straight to the unit for assessment, blood test. And we have got also what we call a door to antibiotic time of an hour. So anyone who's been on chemo, who has a temperature, who has got any sign of infection, will have a course of antibiotics within 1 hour of arriving in the department. And all of these things then help in terms of managing chemotoxicity. In terms of radiotherapy for endometrial cancer is much more tolerated. The doses I use for cervical cancer is obviously much more morbid and causes things what we call radiation pelvic disease. But with this radiotherapy, vaginal brachy certainly is much better tolerated, less side effects. But the things we look out for is for fatigue, change in bowel habit, diarrhea, cystitis symptoms, and then long term they can have problems with vaginal stenosis, vaginal shortening, sexual dysfunction, increased risk of urine infections, and then from particularly older ladies who are smokers, who have got a history of osteoporosis, there can be an increased risk of radiation pelvic bony insufficiency fractures. You know, so we see that more commonly. And then lymphedema. So if you are operating on these patients and, you know, doing a pelvic lymphadenectomy, and then if I give them pelvic radiotherapy, there's a much greater chance of lymphedema, which we know never really goes away, but it can be managed, but it can be quite morbid and debilitating.
There is another question for you, Dr. Rajni. Is any modification in the protocol is required for the rare papillary serous type, and does it to be treated like CA ovary?
Yeah, I think that's a very good question. And we think the high-grade serous papillary is very different to the endometrioid. Its behavior is different. So morphologically, it's different from the others, epidemiologically, and even now we know from the genetic point of view and molecular point of view, it is very different. And there may be a relation between and fallopian tube and ovarian high-grade serous papillary. We also know that in terms of pathogenesis, they don't arise from hyperplasia. They arise from a precursor called EIC, which is the intraepithelial neoplasia. So, you know, so it might actually be more like behaving like an ovarian cancer. And we have had some patients where we've also used a neoadjuvant approach in these patients, and we use that very commonly in ovarian cancer. So if, for example, the cancer is inoperable, it's very bulky, we're unable to get complete macroscopic clearance, then I may downstage these patients with chemotherapy to debulk them to allow surgery to occur. Because we know these patients without any surgery, you know, that their lives will be blighted by this disease. So yes, it's probably in its behavior more like ovarian and fallopian tube.
Next question is for Dr. Anil Ramdas. What are the reasons for false negative in frozen section diagnosis of CA endometrium?
CA endometrium in the sense you mean to say whether the endometrium sample is sent or whether the hysterectomy sample is sent for frozen session.
Sir, endometrial hysterectomy sample. We have done the this thing hysterectomy for the benign, and then we have seen, we cut the portion. We see there is an invasion of the endometrium into mass into the myometrium, and that is come as a negative. But when we sent entire portion for the histopathological sampling, and then report come as a positive for CA endometrium.
I guess the reason for a false negative report will be arising only in case of maybe a grade 1 of the endometrial of the adenocarcinoma, because it is sometimes very difficult to differentiate between a typical hyperplasia versus an intraepithelial neoplasia or an adenocarcinoma in situ, or a grade 1 of the adenocarcinoma which is superficially, which is rather the proliferative type of a growth. Rather than rather a non-invasive of the growth. So that is where the that is the only reason the grade differentiating the atypical hyperplasia from grade 1 malignancies, and this difficulty is more the so in younger patients where the diagnosis is really where the implications are really difficult. So I think that that's it. I guess that's the only reason for a false negative diagnosis on frozen.
So, sir, always there is a correlation between frozen versus histopath findings?
Definitely in 110% if it is a grade 2 or a grade 3 lesion or any any high grade malignancies per se. So only question is whether it is in the typical hyperplasia versus an adenocarcinoma in situ. Those are the areas where the correlation will be slightly difficult. But otherwise, I don't think so there should be a problem with frozen session. Mostly we don't have any problems.
Next question is for Dr. Prashant Bhambre. Sir, what are the intra-op and post-op complications of the radical hysterectomy, and how are we going to manage it?
That will be a lecture, I think.
Thank you, sir. It is, but just give us few points to management so that we can.
Yes, complications can occur in each and every surgery. The only thing is that you have to prevent complications, and if you have a complication, you should diagnose it on table. I think appropriate use of all your diathermy, staying in planes is, and taking all the necessary precautions would prevent complications. And I think the commonest complication, which in endometrial CA ideally should not occur, is a ureteric complication. But I think in endometrial cancer, the commonest so-called complication is lymphatic collection, which is, if you share of the lymphatics, which is most commonly seen. Otherwise, bladder and vascular injuries, I till date have not seen any patient of endometrial cancer having such kind of issues. Ureter, definitely yes. You have to be correct planes, and as it is most gynecologists, all of us are so worried about the ureter. So better idea is identify at the start of the surgery, stay in the plane, and you won't have any complications. So intestinal complications or inadvertent injuries to sigmoid, all small bowel injuries. So large bowel injuries within first 12 hours you'll have patients complaining of pain and all sorts of problems. So you'll diagnose it early. Small bowel or diathermy injuries are the late issues which all of you should be aware of. So to just be careful in doing the surgery. And regarding Anil's this thing, as I said, in terms of endometrial sampling, there are as gynecologists, we blind DNC, as you said, is a good standard. It's not a good standard. Hysteroscopy with endometrial sampling is the right way. Otherwise, you tend to blame the. So I've seen some hospitals doing endometrial curettage during the case and sending it for histopath and then finding it negative and going for the surgery, which is not correct. You can do a 2 minutes hysteroscopy, take a sample, give it on table to the for the frozen, and then see for whether it's malignancy, not a malignancy. In terms of cut specimen, what is said is myometrial invasion. I have seen few frozens with myometrial invasion on histopathology. They differ compared to a frozen. Maybe I think it is still a borderline thing in terms of myometrial invasion.
Okay, now I think this is the last question about, now as of now we are discussing about the endometrioid cancer. Now let us have other type of the CA endometrium. So I think all panelists should give their input about the other types of the CA endometrium. Starting with Dr. Nitish.
I send him over to Sandra.
Yeah, Sandra
Okay.
and I think Rajni take over.
No, but yes, as discussed earlier, grade 1 and 2 needs to have a TLH BSO in a cancer center, cancer unit, and anything more has to be referred to a cancer center, which is where Sandra and Rajni come into it.
Sandra, you can answer if you. Other types, apart from endometrial cancers, other type of endometrial, not the endometrial variety.
Sandra?
I mean, I can start maybe then, while Sandra gets thoughts together. Okay, I mean, I mentioned a bit about the clear cell cancer and the high-grade serous already, and the carcinosarcomas. But a lot of the trials have got sort of three-quarters perhaps endometrioid histology. So they're not very common, and to recruit to trials, for that histology alone is very difficult. We know that high-grade serous does the worst. We know that it needs chemotherapy, because chemotherapy, in addition to radiotherapy after surgery, gives the biggest impact on overall survival. When we look at clear cell histology, that also is a very heterogeneous group of patients. And we've had some patients who had sort of stage 1 clear cell cancer, and by the time they see me, just a few weeks, about 2 or 3 weeks after surgery, they've already got widespread metastasis. So sometimes there may be a molecular switch that gets triggered, and they go from something that's more sort of indolent to very, very aggressive. And we've had patients who, well, maybe a couple that I can remember, who after even stage 1 clear cell surgery was, they died within 3 months. So it is quite heterogeneous. It is, very poorly understood. And it may also respond to different types of systemic anti-cancer treatments. There is a trial in the UK looking at sort of biological agents rather than conventional chemotherapy. There's also perhaps radiotherapy. They're more radiotherapy sensitive than other conventional chemo. And then when you look at other types of, I mean, we're not even talking about sort of the sarcomas over here, but if we look at sort of the low-grade tumors, the low-grade tumors, we just carry on operating and starting, because they're very estrogen receptor positive and hormone responsive. And then we'll just use hormone treatments with them. And I've got a lady who's probably had, maybe about 4 or 5 surgeries over the years, quite extensive surgery. And she's still, in remission with the hormonal therapies. So yeah, so they are a very mixed bag of patients, and their approach should be very different.
Right. Shall I go next then?
Yes.
Now, like Rajni say, I think other subtype, they are, as a general rule, treated from a surgical side of things as high-grade endometrial cancer. So you do, again, surgery is still the mainstay. And as I say, you want to give the best for the patient, and together with Rajni helping with adjuvant treatment side of things. So the more information that you can give our clinical oncologists, then they will hopefully be able to tailor and get a better outcome from this patient. They do behave very differently. You might see some high-grade serous, like you say, that just in the very early stage do really well, but there are some that just progress very, very quickly. And sometimes I think that they're even more aggressive than the normal ovarian cancer, to be fair, because even in ovarian cancer, you got disseminated abdominal disease, you give them chemo, then you do an interval debulking surgery, but sometimes in the endometrium, they just don't do as well, but for what reason, we don't know. So really, for this high-grade, again, carcinosarcoma is something completely different. Yeah, you can do the lymph nodes, they will not recur in when you remove the lymph nodes or radiotherapy, they can sometimes just have distant metastases or recurrence in somewhere completely different. So I think at the upfront, when you get the case from surgical side of things, you want to give what's the best for the patient. So whatever we can do to help Dr. Bana in terms of the next step of treatment, and it's going to, I'm sure that Raji probably will agree that the first treatment you want to give the best and more the information and give them a good treatment in order to really decrease the risk of recurrence. It probably will ultimately still recur, but I think that the best shot is right on the first treatment.
Okay, there is another question for Dr. Sandra. If we don't have a multidisciplinary cancer therapy, what important practical points should be generalized gynae should mention in a preoperative counseling, and a role of para-aortic lymphadenectomy in a type 2 cancer?
So don't have cancer therapy. So basically like 2 steps like general gynecologist or gyne-oncology. I think that is probably what she meant. I think, yes, I think as we mentioned in the slides, if you have patient in the intermediate risk group, so those group are the one that the evidence for lymph node dissection, because the procedure itself is quite high risk, is trying to balance that risk and the benefit. So I always tend to tell my patient and say that, look, the lymphadenectomy does not, I think you just have to be very open with the patient, and then most of them will accept it. They say that, you know, we're not sure about the therapeutic effect of it, and obviously, you know, it's not without risk going through all that risk, but it may help the next step of treatment. So it's not just about the surgery, but it's also helping to tailor the patient into the next step of surgery, what kind of radiotherapy, and whether they need the radiotherapy or not, whether they, you know, following the surgery with a lymph node status, that they can actually just be limited to that. And again, para-aortic, as I say, we don't do it as a routine. We don't do as a routine para-aortic node dissection for even high-grade endometrial cancer. So unless there's just one enlarged lymph nodes, but I tend to do that more for ovarian cancer, more from debulking point of view. So you know, I think you just have to, if you were to perform para-aortic node dissection, it's even more important because of the risk or surgical risk to the patient. It's even more important to actually make them understand that there is no great evidence out there to say that it actually does change the survival, and also making sure they understand in the journey following the surgery what options are there. So if they know that there are options of radiotherapy and they're good, you know, they're good treatment following that, and with a vague evidence of para-aortic node dissection and in endometrial cancer, it may just swing them towards, you know, opting out or not so keen for that. But as I say, we don't usually give our patient an option anyway. We tend to just say, high-grade endometrial cancer, this is what you need. Unless pre-MDT during the multidisciplinary team meeting, and it's all agreed between the surgeon and the clinical oncologist that this patient will benefit from para-aortic node dissection, then we will counsel them for that when we see them.
Fine. Thank you, Sandra.
Thank
that was
you.
useful.
That was really wonderful. And
Can I ask a question, please?
Yeah.
You know, sometimes in our MDT, we always have a discussion about the number of lymph glands. And in some of the radiotherapy trials, you know, we feel that 12 is a good number, 6 on either side. What are your thoughts about the number of lymph glands? And sometimes the surgeon will feel, oh, I've got all the lymph glands, but then the pathologist will say, oh, there's no lymph glands in here. So how do we reconcile, you know, the number? Because that also then, you know, makes me then change my adjuvant treatments based on that?
I'll answer. See, if the lymph nodes, what you're trying to remove, the internal iliac and the obstructed nodes and the common iliac nodes. So if the sheath and everything is clear, all the lymph nodes, that means they are out, correct? So if you can see, remove the sheath of the vessels and all the lymphatics along it, that means it is clear. The number, I don't know how the pathologists clearly number, or numbering 6 and 12 and 14. It's really dicey. If the pelvis is clear, that means we have removed all the lymph nodes. So the whatever existing nodes were there in the patient, we have removed completely, right? That is one of the points. And in terms of big lymph nodes and small lymph nodes and fat, especially you have a problem in terms of patients on the obese side. There is a lot of fat, so you tend to clear and remove even the fat inside the just below the peritoneum, next to the bladder, and above next to the sigmoid. So lots of fat also goes along with it. So I don't know whether they really separate out the fat and the lymph nodes and weigh the lymph nodes per se.
Rajini, can I answer that as well for your question?
Yes,
I'm really glad that we're in the same talk today. Actually, it's interesting. I think it's so difficult, isn't it? I think, like, I totally agree with Dr. Prashant. And I don't know whether the pathologist can give us some input into this. So we do lymph node dissection based on boundaries. So very much you can only remove so much whatever you can see. You know, it doesn't actually say the numbers, how many lymph glands it actually removes, unless they're really prominent lymph nodes. They just look like a bunch of fat. I even have junior staff is like, after about half an hour doing the surgery, they say, "Why do you remove all this fat?" and I would find really thin lady, they tend to have less lymphofatty tissue compared to the large lady. And I think also in some lady, the shape is all very different, where you deep down inside the pelvis, when complication happen, and that kind of thing can limit where your boundary can go. But as a general rule, we go by boundaries. So after you remove all that, then you can just send to the pathologist and let them decide the number of lymph glands. So it's a very interesting one, because I think UK tends to have less lymph node counts compared to European country, because they're talking about 20, 30 lymph nodes, which you'll be very interesting to actually go to a laboratory in European country and see how they actually process these lymph nodes actually.
That's excellent.
I think, Rekha, your question about para-aortic lymph nodes is very clear. I think it's para-aortic debulking surgery is more significant only in ovarian malignancies. It does not have much of significance in endometrial cancer. I think that should answer whatever remaining questions are there, which I can see on the chat.
Yep.
I think we have come to the end. All questions have solved. Yep. And this is an excellent discussion about the comprehensive management of CA endometrium. And I would like to thank all the respected speakers and chairpersons from my side. But I would like to invite Dr. Datta Panandikar to give a vote of thanks officially. Can we have Dr. Datta Panandikar on the?
Yeah. Can you hear me?
Yes, very well.
Yeah. So thank you everyone for this very comprehensive evidence-based discussion on CA endometrium. I thank the whole North Midlands team, Dr. Nitish Rao, Dr. Sandra, Dr. Rajni, and our own dynamic Dr. Prashant Bhamre for their excellent lectures. Thank you, Rekha, for moderating the session so well. Thank you, Priya. Thank you, Niranjan, for being our chairpersons. Thank you to our president, Dr. Laul, who put so much effort behind each webinar. Thank you very much for the entire, thank you, Anil, for being a part of this, of the discussion. Thank you, the entire team of Swizera, Mr. Mukherjee, Mr. Patania, Brunalini, Smita, and thank you all of you for attending this excellent session. I think as a team, we are doing a great job having a webinar almost every week. on different topics, and we have always had almost a 150 plus attendance. So thank you all of you for attending this webinar, and see you next Sunday. Thank you all of you, all the speakers, all the chairpersons. Thank you very much.
Thank you very much, TOGS Society. Thank you very much. On behalf of Swissera, I am Ranjit Pathania. Thank you very much for all.
Thank you.
And thank you for a nice webinar.
Thank you.
Thank
Thank
you.
you.
Bye.
Thank you very much.
Take care.
Bye-bye. Stay safe.
Bye, Rekha.
Yes.
Thank you.
Bye. Bye.
Bye.
Yeah, thank you. Bye, Thunder. Bye, bye.
All right, then. Bye.
Bye, Rajini.
Rajiv sir, can we end the session?
Yeah.
Yes,
End the
Yes,
session.
sir. Should I end the
Recording
session?
post kar do.
Yes,
Ah,
yes,
sir.
definitely, Dr. You'll get it. Thank you. Thank you very much.
Thank you very much.
Thank
Thank
you.
you. Bye, bye.
Thank you.
I'm ending the session now.
Yes.